I'm going to call this meeting to order. Secretary, if we can call the roll.
Assemblymember Brown May. Assemblymember Dickman. Assemblymember Hafen. Assemblymember Hibbets. Here. Assemblymember Howdegi. Here. Assemblymember Monroe Moreno. Assemblymember Yeager. Here. Senator Canizaro. Senator Dondero Loop. Here. Senator Stone. Here. Senator Titus. Here. Assemblymember Mosca. Here. Chair Wen.
Here. And if we can mark our other members as they arrive. I anticipate everyone will be here today. And we have a very packed agenda that maybe isn't reflected in just the 4 items that are on the agenda, but we are going to try to power through this as best we can to try to get through this and get all of the questions answered and asked. So we will get started, and if we can ask, I believe we have Administrator Weeks here, and I don't know if she's just up here solo, or maybe she has some support team. I'm sure she has phone a friend. So if we can go ahead, please state your name for the record, and we will start with the Medicaid administration budget, 3158, and go ahead and begin when you're ready.
Good morning, Madam Chair, committee members. Stacy Weeks for the record, Administrator at Division of Healthcare Financing and Policy. I have with me here today Deputy Administrator Jennifer Krupp and our ASO4 Lynette Aaron to help answer questions this morning. I also just want to acknowledge that there are over 60 slides, and I promise it was not to bore and make this very painful. We'll do our best to move through some things pretty quickly and then just get to the meat of it, which I think all of you might appreciate this morning. And so with that, I'm going to flip pretty quickly on these few overview slides because I think many of you saw this during our pre-session. As you know, the Division of Healthcare Financing and Policy oversees Medicaid and healthcare coverage in the state for low-income families. This is our leadership team. I just want to give a shout out to the hard work of this team. Often I sit here and get to take a lot of the credit, but really it's the people that work for me and work on these programs that really should get the credit. We have a good team and we work very hard, and these jobs are not often easy. The summary here, I think you guys know, we pay for healthcare, we do the provider enrollment, we oversee the managed care plans, all of those pieces. The only thing right now that we currently do not do is eligibility enrollment. It's under DWIS. We are recommending that a portion of eligibility come back under the Nevada Health Authority, the eligibility policy team. The governor is recommending that it come under the Nevada Health Authority, under the Medicaid director, and then we look at making that real-time enrollment through the exchange. I just want to note an error here that was identified last night at the hearing. The second line on that table should be $15 billion. That's kind of the average-ish when you think of state and federal funds that go into Medicaid on the biennial spend. As you can see, Medicaid is statewide in this state. I think you guys know all the statistics. We cover 1 and 2 births and nearly half the children in the state. I talked about this last time during our pre-session, but we've had a lot of things happen since we last sat here in front of you last session, including we went through an unwind where we redetermined eligibility for all 8. At that time, it was over 900,000 people. Our DWIS team did a lot of work on that, and we worked with the exchange and providers to ensure that people who were eligible tried to get back on if they were kicked off, and trying to ensure that people got the coverage, or if they weren't eligible, that they were not on the program. By the end of the pandemic, just so you guys know, before the unwind, our program had grown by 40%. Now, after the unwind, after the pandemic, we see that the program has actually roughly grown 22%. So some of those folks have come off. There could be still people coming back on. Often people do fall off because of paperwork. And already we've seen nearly half of the 300,000 people that were disenrolled during the unwind come back. During the pandemic, also, we saw a 6.2% increase in federal share. During that time, we got enhanced FMAP because of the pandemic. That went away, and now we are facing about a 2.42% decrease in FMAP over the biennium. And here's a slide just walking through the FMAP. As you can see, by the end of the biennium, next biennium will be at about 59% federal share. The rest will be state funded. This here is just the pie chart of our spend. This biennium, we have spent about $15.8 billion in Medicaid. About 60% of that spend, which is almost $10 billion, comes from the federal share. The other is county share, provider taxes that also are matched with federal funds, and then the general fund, which is what you guys, I think, are trying to balance here today, is the $2.5 billion that we spent last biennium. And then ongoing, as you can see, the governor's recommending a slight increase in each of these buckets to address costs that are growing in the program. The caseload in front of you is what we had when we put the budget together. I do want to talk a little bit at the end of the deck today about some changes we're seeing and expecting in caseload that we would like to offer an amendment to adjust. When you look at where we are right now after the unwind, we are about at 788,000 people, roughly 800,000 is a fair number to pick if you're going to pick one in the sky right now. But as you can see above where we are at the end of the session, we thought we would actually have 850,000 people, but we have a lot less than we've expected. But we do expect at the end of the biennium for some of those people to come back, so be back over 800,000 people. Our checkup is what we call our CHIP program. It's a Children's Health Insurance Program under Title 21 of the Social Security Act. This is the program where it flipped, right? So we thought we would see a lot lower because historically that has been a small program. But what we found is a lot of these children during the pandemic whose family maybe lost their job and they were lower income, have gotten higher incomes, but not high enough that they're not qualifying. And so they stayed on the program, but they're now in the CHIP funded portion of the program. So they went from the Medicaid, the lower income piece of the scale, and went to the CHIP program. So we see a lot of our members being put into the CHIP program for children. I wanted just to make sure there's something I think is important to note, just because we have, as you can see in this slide, parents and children are the majority of our enrollment, but that doesn't mean they're the majority of our spend. In Medicaid, it's not about the size of the enrollment for the costs of the population. It's really about the services and the acuity of the population. So as you can see, the pies don't match up. Enrollment sizes do not always correlate with spend, as you can see in that pie. 26% of our spend are actually adults without children, and then 31%, which is the bigger bucket, there is our child welfare, foster care program, and our home and community-based waiver programs for people with disabilities. This is just a snapshot of all the funds that we have in our program. Today, we're only here to walk through a couple of these, and then I know there's another hearing coming up that will finish these, but this is what we were proposing is in front of you. There are amendments that we've already discussed when the governor's office did their budget amendment that will change some of these numbers, but we wanted to give you a snapshot of what was originally proposed. So let's dive into what we call our admin account, 3158. This is an account that we do get federal match for. Typically, for general operations, we get federal 50% match. For our enrollment and eligibility system and our payment system and medical staff, any of our clinicians, we're able to draw down 75% FMAP, our FFP, and then 90% for our implementation of technology, eligibility enrollment, and some of our systems work. This account also funds all of our staff salaries and our buildings and offices. We're recommending several, first we'll walk through the mandates, and then we'll walk through the enhancements. The first few here are compliance activities that we're asking for funding to continue. The first one has to do with our actuary services. We have to continue under federal law and actuary to set rates in our managed care program. So they do our rate setting annually. They also look at our medical loss ratio as well as our risk adjustment and any money that we should be getting back from the MCOs. This contract for the next biennium, we're asking for additional funds. Part of this has to do with the program has gotten a little bigger with the statewide managed care, but also we are adding a specialized managed care program for children with behavioral health needs as part of the DOJ settlement agreement. And we're also looking at following the audit that came out from the state around non-emergency medical transportation services and ensuring that contract has actually sound rates. And so we're asking for funding to do that. And we are getting ready to go back out to RFP for this bid for a vendor to provide these services. M503 is our home and community-based waiver services. We have a federal rule that sorry, it threw me off for a second. We have a federal rule that came down right before the administrations flipped, and it had many components to it, but one component has to do with better oversight and support for recipients in our home and community-based service programs, our waiver programs. While they are administered through ADSD, Medicaid is the funder and is essentially responsible for that program under federal law. We are asking for additional positions to support a new grievance system and an independent review of recipient grievances that go through the ADSD side, as well as with our providers, and also an incident command center we have to set up for issues that come about in that program. M504 has to do with new coverage. This was part of it seems like a long time ago now, 2022 Consolidated Appropriations Act that passed at the federal level. It required states to start covering the juvenile justice population, which, as you all know, right now, we cannot cover that population. They are considered detained and under a court order, but this would require states as of January 1 this year, which we have started, to cover populations that are 30 days pre-release in these facilities. And so part of this effort, we need 2 healthcare coordinators to support the facilities and ensuring that these individuals, as they're leaving juvenile justice population, that they have care coordination, that they're being set up with appropriate supports and services in the community, and that's part of the requirements. Federal compliance and hearings at the bottom here. In Medicaid, it's an enormous amount of regulation that we constantly have to follow. And in addition to state law and state issues, federal compliance continues to be one of the biggest pieces. And we really don't have a dedicated team, I would say. Until recently, we kind of created that internally. And so we really need some additional staff to support that team so we can also ensure that team isn't bogged down with the hearings. This team also does the hearing support. So we're trying to ensure that team has the support they need so we can remain in federal compliance. We've had a lot of federal audits recently. I expect more to be coming to look for fraud, waste, and abuse. Having a federal compliance team to ensure that we are in compliance with regulations is really important for us to be able to respond to those audits. This here is other items that we need to maintain basic compliance and services. Provider screening enrollment. We continue, thankfully, to see more and more providers enroll in our program. But we have seen, more and more providers having to revalidate, and that is a process. And we're asking for additional staff to come on and support that team to ensure that we are able to best assist providers. I will say this is the one area where I get emails every day. This is the area that unfortunately continues to be the one I hear more about. A provider cannot get enrolled. I think we heard it last night from a provider. And so we're really trying to improve that process. We're revamping our online system starting hopefully by the end of this year. But having additional staff to support that would be extremely helpful and help us remain federal compliance. M507, this is something all states are dealing with. And I'll just say that it continues to be a concern. AI especially has allowed cyber attacks as well as fraud to be a lot easier and more sophisticated than we've ever seen before. We had the Change Healthcare cyber attack. I think it was last year. It feels like a long time ago. Yeah. But it really froze a lot of our payments. We could not get the claims that we needed to be processed appropriately under federal law, so we could not pay out a lot of our personal care providers. It was on the news. It impacted our recipients who rely on these services. So because of all of this increased risk and what we're seeing in other states, we're asking for additional IT staff to support these risks from cyber attacks and ransomware. Under M510 is our Medicaid Consumer Advisory Committee. We also have a BDR, a budget BDR, to address these issues here. This is, we currently have a Consumer Advisory Committee, but federal law requires every state does, but they updated their rules and they have new requirements, including that we ensure that we have actual recipients on this committee, which I think we all agree is the right thing to do. Right now, it's primarily providers. So it's a balance, it's balancing that out, but it's also asking that we fund and pay for travel for those recipients so they can, if they want to travel and be in person, that we're helping support their participation. So that's a small cost there, but as you can see, that represents that compliance piece. M512 is our external quality review organization. We also often call that our ECRO. This is our managed care quality review organization. We are required by federal law to have an ECRO. Yes, the funding always grows for this work, but we continue to have to look at more and more quality, report more and more things to federal government, and as we expand statewide managed care and potentially have 5 plans and not just 4, we do need additional funds to support that work. Next slide. These are our enhancements in addition to things that we're asking for related to compliance. We're asking for additional staff and support to set up a single preferred drug list across managed care and fee-for-service benefits. This would be our outpatient drugs, and it really will support, I think, some of that streamlining, simplification for providers. Everyone will know what's covered, and there won't be a difference in whichever program that you're in or plan. It will also help us maximize rebates for our program from where we are today. So there is a savings component to this, but it is it's in a different budget account that's not here before you today, and we'll talk about that in the future. But to pay for the staffing that we do ask for additional cost, we are asking that we fund some of these services out of the rebate funds to help support the cost of these staff. E253 is our non-emergency medical transportation program. This benefit, I'm sure many of you have heard, a lot of people struggle with getting access to transportation in our program. And so what we're looking at is improving our development and oversight of our NEMT vendor and looking at going back out to bid in I think a year or 2 from now and trying to do a better job on the contract as well as the payment. And we actually need someone really supervising and monitoring that contract and holding that vendor accountable. So we're asking for additional staff. E255 is continuation of our oral health program. We currently have been able to, with Dr. Benson's help, our dental health officer, we've been able to maximize and get new grants from CDC. We also have our federal HRSA grant. This funding will just maintain some of that work that we've been able to do as those grants expire and ensure that our oral health program, which is under Medicaid now, it used to be under DPPH, is able to support the communities, especially our rural communities, with dental access. Next slide walks through E262 is our healthcare workforce initiatives. This was a big piece of the governor's budget proposal. We're asking to fund additional positions to oversee the new work we're trying to do, where we're trying to maximize, for the first time ever, I think, where we add state share, actual state general fund money, to support providers who do graduate medical education or any type of training programs. Looking at doing that through Medicaid reimbursement, like an incentive bonus payment. In addition, we're looking at states like Florida who have been able to maximize federal funds to even support some infrastructure work around GME. So we're talking to them about how they were able to accomplish that. But these funds that we're asking for need additional staff, and this is asking for that staff person to help support that work. And those funds that we're asking for are not in front of you today. They're under the rebate, the pharmacy rebate account, and we'll talk about that in a future meeting. E275 is, you maybe have heard of what we call our BCCP program. It is our program that supports individuals in our skilled nursing facilities. It provides skilled nursing facilities an additional bonus payment, essentially, to support patients that have really complex behavioral health needs, in addition to medical needs in a skilled nursing facility. We're asking for additional funding. This would be coming from our provider tax program, which is consistent with state law, that we support moving individuals who are stuck in our ER, often especially in our rural areas. We have individuals who have complex behavioral health needs and complex medical needs that should be in a skilled nursing facility, but often the skilled nursing facility is not equipped to take those types of needs. And so this program is really supporting that, and adding this quality bonus payment program is really trying to, we're focused on ensuring that hospitals and our skilled nursing facilities have some sort of care coordination agreement as part of this program, and they meet certain quality metrics for these transitions to the community. E301 is the item I mentioned earlier. We are hoping to, as part of the Nevada Health Authority, or even if that doesn't pass, regardless, we're hoping to work with the exchange to ensure that like some states are looking at, that we can automate Medicaid enrollment through the exchange. It will be real-time eligibility. For a lot of our individuals, they don't need a caseworker to do some of the work that they need to do. They can enroll online and be automatically enrolled in Medicaid. We asked for additional staff to help support this program. As you can see there is some vendor funding. Some of this also is coming out of the rebate account too. E303 is our professional development and staff training. I know that this item maybe doesn't seem as important sometimes in the scheme of things and services, but one of the things that we know that we need to do better at our division is really supporting the professional development of our staff. Medicaid is a very complex program. We want to ensure that we're able to send staff to certain conferences so they learn what other states are doing and can bring that back. We do have a travel budget now, but we're asking for additional funding and staff to support that work. We're asking for a training officer so we can better train folks when they come into our division. And we really think that this will help create a pipeline so individuals, as they grow in the program, they can move up and become leaders. Next slide. This first item is something we've been working on originally with UNR, but we are talking to UNLV. We're setting up a Medicaid academic partnership like many other states have, where the university puts forward state share, their local funds, and we draw down federal funds. And the one that we're working on right now that is reflected here is that they would hire a variety of clinicians that support Medicaid. Right now, for example, it'd be nice to have a gerontologist that could support our program as well as ADSD. And so some of this funding could go to someone that has those skill sets, including pediatrician, someone with behavioral health, psychiatric education, some of those needs. So we're working with them to try to find staff on their side that also can be supporting Medicaid, because often it's hard for us to hire those individuals. Dental hygienist is another item here. This is actually required under state law, under 439279. This is just funding to continue our state dental hygienist pursuant to that state law. E599 is ARPA funded positions. This is just continuing many of the positions that you guys funded last session through ARPA, and we would like to continue these. This includes our pharmacist, who has been an amazing asset to our team, as well as all the other positions that you see here that have really been helping us, especially in our HR side. With this additional personnel analyst, I mean, we have seen our employment rate go up extremely, and our capacity increase. We're down now to 8% in vacancy rate. E808 is our fiscal services operations. We're really looking right now we have a student worker position, and I will be honest, the way it works, it's asking a student not to go to school to be able to comply with the requirements. We can't hire anyone for this job. So we just want to bump it up to an accounting assistant so we can actually fill this position to support our accounting team. This here is talking about different transfers that we have as part of, I think, the Nevada Health Authority, and I do have a visual here in a second for some of these efforts, so it helps at the end here. E900 includes the various positions that would be coming over as part of the eligibility policy team to be working under the Medicaid program and the Medicaid director and working on eligibility. E901 would be transferring several positions from ADSD to improve some of our audit and oversight of providers in that system. Currently, our division does not have oversight of those programs and providers. E902 also includes some of those positions. E903 includes one position from OSIT to come over with the graduate medical education program. So in addition to us asking for funding to improve Medicaid reimbursement, the governor's proposal includes moving OSIT, the graduate medical education program, over into this new agency. Vendor resources. This includes support for our nursing facility provider tax program. This is no cost to state general fund. We'd be using administrative money that we are able to collect from the tax revenue. We're asking to do this so we can get Mercer on contract to support that provider tax program. We've had a lot of issues, I will be honest, with trying to set some of this up and move forward with the tax program. We really need the consultant support to help address that program. E256, we're looking at increasing the cost of contractual obligations in our budget, and this just includes some of those items. E258 is modernizing and improving and financing for mobile crisis services. This is an important one as we look to go to address the DOJ settlement agreement for children's behavioral health. We're working in conjunction with DBPH on this item and trying to ensure that we have statewide access to mobile crisis. And as you guys know, that's not easy. This would fund money for a contractor to help us reform our rates and ensuring that we're able to support all levels of mobile crisis. Not everyone can meet the new standard model that, which we all want everyone to have. But in the meantime, we need to support all types of mobile crisis in the state. These are just the funsies, the equipment. I'm going to move forward. They're still important. We need equipment, so there's those items. Funding eliminations. This just is clear on some of the items that will be expiring under our budget, including our HRSA grant that is ending, as well as the ARPA grant funding. All right, so we're on slide 23. We're moving into some of the items that are under our admin account that we think we can match with federal Medicaid funding for the new Nevada Health Authority. There would be a new director's office within the new agency. It would be there's several positions that we need to fill that out, and those are included in E280. E281 is a new purchasing unit that we really believe is necessary when we look at a new strategy for purchasing healthcare across all different carriers and figuring out ways to leverage the Medicaid lives that we currently cover. So there are a couple positions here that are needed to oversee and support that unit. E282 is also our healthcare purchasing and compliance division that would be under this new authority. As I mentioned, I think before when I sat here, we are moving over what we call our SUR team, which is our surveillance utilization review team. They do fraud, waste, and abuse. We're moving them out of the program, so they're independent under a new unit with healthcare HCQC, which is our healthcare compliance and licensing unit over at DBPH. They would be under one deputy director and have the support of a regulatory and compliance council. We hope that this would really help elevate some of those efforts to reduce fraud, waste, and abuse in the program. The next slide includes E283. We do need one more ASO to oversee our provider reimbursement unit. We have, we oversee a very large budget. It's about, like I mentioned earlier, $15.8 billion and growing. We do have, I would say, a lean budget team, and our provider reimbursement unit does complex calculations and works with Mercer on trying to support all of our supplemental payment programs and our provider tax programs. So we're asking for a new leader to oversee that unit. And it would also be part of the Nevada Health Authority. E284 is our Enterprise and IT and Innovations Office. Because of all the new work we would be doing with the exchange as well as PEB to automate and make things easier for individuals to get into their coverage, see their benefits, look at their provider networks, we're asking for an IT deputy director and project management position to support that work for the whole department. E286 is our Consumer Health and Access Division. This is where the Exchange and Patient Protection Commission and other work around consumer health will live in the new department, and we're asking for a deputy director to oversee that part of the division or department. And then last, and then we'll move to the visual, so hopefully it will help. E810 is additional support for the compliance division. This is just taking one of our current position, our social services chief, and reclassing that to health bureau chief, and making sure that as we expand responsibilities under the new authority, that position is also recognized in that. E811 is our Nevada Health Authority director. Instead of creating a new director position, we're asking that you take the division administrator position and reclass that to a director position, which will continue to be the Medicaid director for the state. E815 would be taking our current agency manager, which is our compliance officer at our division now, and reclassing that to be a new deputy administrator level to oversee our Medicaid Inspector General unit. And so like I mentioned, we're trying to really beef up our efforts around fraud, waste, and abuse. E816 is our new healthcare financing and budget team. This would be the department's budget team, and we're moving a lot of the Medicaid budget team under here, and we'll be like in the exchange and PEB, because they are so unique, will continue to have their own accounts, but we want this team to be able to support the whole department. We're asking that we reclass one of our deputy administrators currently in our division to a deputy director to oversee that budget. This here is a snapshot of the organizational chart as proposed. As you can see, we talked a little bit about the director's office, which is our chief of staff and operations office, our chief IT and enterprise office. Right now, Office of Analytics is under the DHHS. That will be coming over. We're not asking for any additional changes there in our budget in this account. Healthcare purchasing compliance included several positions we've talked about. Healthcare financing and budget team would be moving over. Like I mentioned, the exchange and PEB would maintain their own unique budget accounts and teams. But really the goal of this team is looking at ways to maximize federal funding across the entire department. Nevada Medicaid remains here, which is the division today. We're asking that it be renamed Nevada Medicaid so it's clear exactly what it is. Consumer Health and Access includes PPC, Public Option, GME, and all these other items, and then Public Employee Benefit Program. Just real quick, some of the things I think we haven't had a chance to talk about, so I wanted to sort of highlight, is that when you're putting all of these together, the goal is to really align state priorities in healthcare the way they have not been aligned today. PEB, Medicaid, and Exchange, we are all working on in different ways on improving access to healthcare for recipients. Aligning that work can better leverage these efforts and maximize our resources and make sure that we're all trying to tackle the same things so we have a bigger impact. HCQC is also part of this. I'm looking at facility licensure and better oversight of our programs and fraud, waste, and abuse, which really aligns with what we're trying to do in Medicaid, and ensuring that those two work together to ensure providers that want to provide services in this state are able to. This includes also improving quality of care across all of our programs and markets, increasing provider network adequacy, and lowering healthcare costs, which we know impacts not just the state budget, but employees, their bottom line, as well as residents. And then bringing these programs together also helps us to align those efforts, reduce duplication, and maximize resources. Real quick, just some of the examples. I won't go through all of them, but I just wanted to provide, people have asked, what are the gains and efficiencies? There's so much and when you reorganize, I think the department is a very complex entity. It's a provider, it's a regulator, it's a payer. This is really attempting to remove some of those inherent unintended conflicts in that system. Having a provider regulating itself is really challenging. So removing that and pulling that out of DHHS and moving that under the health authority. Also supporting and leveraging greater of our federal resources in Medicaid that are already should be going to support anything that's supporting access, because that is helping us in Medicaid, and quality of care. Combining our payers also helps increase our state buying power. It simplifies access to coverage programs for consumers under one umbrella. So there's one place they need to go if they're eligible for state coverage or public benefits for coverage. It also leverages Medicaid's healthcare purchasing coverage expertise, including our clinicians, to support PEB especially. We all know that they are not a very large team, and we hope to be able to leverage that. We could also look at maybe also being able to do, for the first time, direct provider contracting. We saw this issue with Carson Tahoe being out of our network for employees, allowing us to have capacity by allowing Medicaid to support PEB. We have more capacity to do the things we need to do to meet the needs of these employees. Also, we have multiple actuarial and vendor contracts in this state, all doing similar things. We should have one. We should be looking at that in the future. That's another item we can be leveraging and aligning across all of these programs. And just data. And like the other day I was talking to the Exchange. We have an all payers claims database we're setting up at Medicaid. The Exchange could leverage that data to understand their population. We could be looking at what are the top conditions by region? What are we doing for employees? What are the differences between these markets and why? Right? We need to be looking at that data and to do that together under one house and to really align our work to really improve these outcomes, I think would be very meaningful for the state. All right, that's enough of that. Position summary, sorry. Right here, as you can see, we have our new agency transfers. We walk through those. We have new agency positions we're asking for. And then we have the DHE, our regular division enhancement units and positions. All right, my favorite account, our most complex account, but most meaningful account, but also our CHIP account is also meaningful too. But any of our medical service accounts are they're the heart of our program. So 3243 is our
You know what? I'm going to have
medical
you stop kind of right there
Yes.
before we move into. I know that they're very connected because one's the administrative budget that administers all of the fun stuff here. But I just think before we get ahead of ourselves, and we can stop there if that's okay. Okay, with that, we will jump right into this. I think the first person that we have on our list here is Senator Dondero Loop.
Thank you very much, Madam Chair. And I'm going to ask a couple questions about the changes associated with the federal mandates. So the M ones down to from 503 to maybe like 512, those areas. So Can you talk to us a little bit about the need for those 5 positions, including the social services manager and social services chief, to oversee the new grievance requirement associated with the final access rule?
Chair, committee member Stacy Weeks for the record. Yes, the new federal rule that came out requires us to stand up at Medicaid a new grievance system for individuals who are having issues and getting services, and if they have a grievance with the current program, which may be at ADSD, to have a neutral party overseeing and looking at that complaint. And then we would have to take action or make recommendation to ADSD. We need positions to do that work. Currently, our HCBS staff are very slim and a small team because most of the work is at ADSD. So we're trying to build this into our house because of the federal requirements.
So thank you. So just kind of a addendum to that question. So if the is there any chance, I guess, and if we all had a crystal ball, is there any chance that that federal requirement would change due to the changes in the federal government right now?
Chair, committee member Stacy Weeks for the record. Yeah, we don't know. Of all the rules, this one we haven't heard about. I do think some of the access components of so there are 2 rules. There's the managed care rule and access rule, and then there was a piece of it that was HCBS. The pieces that we have heard that may change are the provider tax and the provider access pieces, but we have not heard any rumors around this rule, so it's hard to know, to be honest.
Okay, thank you. Follow up, Madam Chair? So given that Nevada is currently in compliance with those federal requirements related to the provision of fair hearings, why are those additional positions then recommended to maintain a federal compliance?
Chair, committee member Stacy Weeks for the record. I remember this question. So our volume increases. We are still seeing many of these hearings not moving quickly enough. Due process is important, but also this team is also the one that reads all our regulations. We're trying to support that team and ensure that we're able to keep up with all the regulations, keep up with all the hearings in that unit. We feel like if we don't have that over time, we're not going to be on top of due process as well as regulations.
Thank you. And Madam Chair, may I keep going? What impact was made by the social services program approved by the 82nd, the 2023 legislature to represent that agency at administrative law hearings?
Chair, committee member Stacy Weeks for the record. It was helpful, but like I said, we still continue to have issues with we're in compliance, but whether or not we're doing things quick enough around due process has been a challenge. We also do our hearings. We have a team that supports the hearings, but we go through Office of Administration or Department Administration for our actual hearings. And so they are also backlogged. And so we are affected by that. And we're trying our best to keep up, but the entire system right now is backlogged in this space, on provider and recipient side.
Okay. And then finally, I don't think we've had any violations, and we're in compliance, but what indicators suggest that Nevada Medicaid may risk federal sanctions related to provider screening and enrollment if additional positions for provider screening and enrollment are not approved?
Chair, committee member Stacy Weeks for the record. I think as we continue to have increased provider enrollment, it's hard to keep up with all the revalidations that we have to do, and also just ensuring that those providers are maintaining all of the adequate licenses for all their staff. It's a lot of work. I would say not just the enrollment piece, it's the revalidation that our team is really was behind on and now has caught up, but we're still seeing a backlog, right, of people coming in. And now as that program and our provider network grows, we're trying to keep up with that.
Okay, thank you. Thank you, Madam Chair.
Thank you. I do have just a follow-up question regarding the need for these positions. Can you kind of give an explanation as to why we need 2 upper-level managers to kind of oversee 5 people? Seems like a disproportionate number, but I'm wondering what the thinking is behind having those 2 kind of upper-level management positions.
Chair, committee member Stacy Weeks for the record. Are you talking about the Office of Hearing and Appeals?
I'm talking about the social services manager and the social services chief that would oversee those new grievance requirements associated with those need for those 5 other positions.
I would have to follow up with you about certain roles and responsibilities for those positions, if that's okay.
Oh, no, that would be perfect. I'm just curious to see what that structure, it seems like a very management top-heavy kind of structure.
Chair, committee member Stacy Weeks for the record. We often have chiefs over managers who run teams.
Okay. Thank you. Next, we'll go to Assembly Member Mosca.
Thank you, Chair, and thank you so much for all of this. I know we're going to learn a lot today. And thinking about a similar but a different role, can you discuss the need for the IT professional and management analyst position to support cybersecurity, including job duties and expected benefits?
Chair, committee member Stacy Weeks for the record. I would have to follow up with you on the day-to-day duties and jobs of an IT position.
Okay, thank you. And then similar is the need for the additional position to support the statewide expansion of managed care, knowing that we approved 2 positions last session.
Madam Chair, Stacy Weeks for the record. Yes, at that time, we thought we would continue 4 plans, but we are looking at potentially having 5, but I can't speak to that because we're in the middle of negotiations.
I think next up, we have some questions from Assembly Member Monroe Moreno.
Thank you, Madam Chair. And moving on to it's on. Do I need to move closer? Yes. I've never been told that I'm quiet. I have a big mouth. Good morning. Thank you for being here. My question's on the first one, and I do have a few, Madam Chair, if that's okay. Thank you. It's on the non-emergency medical transportation. It's the E253. Could you just discuss with us some of the concerns Medicaid has with the current non-emergency transportation vendor and the contract? I know that there's one, and you're looking to add to that. Could you discuss that a little?
Chair, committee member Stacy Weeks for the record. I think the biggest challenge that we're currently seeing is that our vendor is struggling with meeting the needs of rural areas, but also even our urban areas. There's a high reliance on Uber and other things, which sometimes makes sense. But we're looking at ensuring that maybe if we're not paying them enough, so we're looking at the rates, but we're also thinking about, is there a better model for providing transportation? So this vendor support would be looking at different models that we could possibly use instead of what we currently have. We are asking the MCOs to pick up some of these services in the rural areas going forward because of the challenges, and we are hoping that because the MCOs have reserves and they also have community reinvestment dollars, that they can help these rural communities invest in some of the transportation services that currently they don't have. When we went out to a rural hospital visit over a year ago, one of the hospitals told us, we had a car, we didn't have a driver, we needed insurance, but the vendor couldn't help us with that, and then when they got all of that done, the person they had that was going to drive passed away. So like all the challenges in the rural area that can go on for years. And so we're hoping that the MCOs and their contracts right now that they're putting together with their providers, and I'm not part of the procurement, so I don't know what came forward, but one of our big requests in that procurement was, what are your creative tools to addressing all of these challenges in the rural areas around transportation? So we're not having to use ambulance and other high-cost transportation services.
That just kind of hurt, that statement. And in our rural communities, we already know that, healthcare is few and far in between. Is there, will they also be looking at trying to help new businesses get started in those communities to help with that?
Stacy Weeks for the record, yes, that is one of the things that we were really trying to encourage through that procurement, is that they would be investing in infrastructure. Some of our communities didn't have an ambulance, so those are things that the actual managed care plans could help invest in with those community reinvestment dollars. Our urban areas, part of why we want this additional vendor to support our fee-for-service or this vendor funding to look at our model for fee-for-service is, is there something we can do different? Maybe it's better understanding where people are and pickup times and all of those things. Is there something, for example, technology we're missing? So this vendor and this work is really trying to help some of our fee-for-service side where we are struggling on improving access.
Perfect. She did approve me for questions at the beginning, so I'm going to go on. In the February 2022 report, there were recommendations, that Executive Branch Audit Division report. Could you discuss if the recommendations as submitted would allow the agency to address all of the identified audit findings. I know that's a lot.
Chair, committee member Stacy Weeks, for the record. Not all of those items were related to Medicaid, but the goal is to definitely address the one around what are we paying this vendor, which I think really gets at one of the biggest issues, and ensuring that those rates that we're paying are sound, but also enough for them to be able to provide better access. So our goal is to meet that part of the audit and address those issues.
And then, Madam Chair, I just have two others, and they're on.
Go ahead.
Thank you. So moving on to our the oral health program, E255 and E491. What's the long-term funding has the oral health program identified over the life of the current grant that we have?
Thank you. Jennifer Krupp for the record. Can you hear me okay, or do I need to get closely? Okay. Long-term funding, we are hoping that the HRSA grant is reauthorized and that the agency would be able to reapply for these funds. If that were the case, then, we would, revert these general funds that we're asking for to maintain these positions. However, our state dental officer, Dr. Keith Benson, has done a wonderful job of applying for additional grants. We recently received another CDC grant. Excuse me, I always get nervous when I get up here. But we also just received another 5-year CDC grant that will help support some of these activities, as well as the continuance of the ARPA funding that is supporting some of these programs as well. So we are looking at basically any federal funding opportunity that we can apply for. However, we have seen such tremendous gains in this program that it is something that we very much would like to preserve.
And as in every budget item in the last few weeks, there's been kind of some up and downs. We don't know what's going to happen. Have you seen anything coming out of the federal government that would not continue to support this? Have you seen that in any lines moving forward?
Chair, committee member Stacy Weeks, for the record. I think we're all sort of holding our breath on that, to be honest.
That seems to be the collective thing that we're all doing. So my last thing, Madam Chair, would be workforce development, the E262 and E903. How would the duties of the recommended new positions supporting workforce development initiatives differ from those of the positions recommended to be transferred from the Office of Science, Innovation, and Technology?
Chair, committee member Stacy Weeks, for the record. So those are two different efforts, and I know it gets confusing because they both say GME. So when you think of the Nevada Health Authority and the governor's recommendations, there's 3 buckets, right? So E262, which is the Medicaid portion. This is an item that we had come forward out, thinking about over the interim of how do we better put forward state dollars instead of waiting for the localities to find that money to match to support GME and reimbursement. And so, for example, UNR and Renown do a lot of this today, where UNR puts up the local funds to really support their GME program, and we're able to supplement their reimbursement to really help indirect and direct medical cost for those programs. That is what this unit is really focused on, and we need an individual who can keep up with all the state plan pieces, monitor the funding, ensure all the rates and supplemental payments are working. The other bucket of funding is OSIT, and that is our GME funding, which really sets up the slots and infrastructure, right? The infrastructure funding for GME that has typically been overseen by a committee. That piece is coming over, and there's an analyst that works and runs that fund. We need to bring that over. The third component, which I know is not in front of you yet, but just in the healthcare policy bill that the governor's put forward, is funding for a larger grant healthcare access fund that really looks at infrastructure needs in the state. So that's another item. So so the E903 has to do with the OSIT GME analyst who runs that fund, which is different. And then this is the Medicaid support we need to support new supplemental reimbursement payments programs for providers and hospitals who do GME training programs. It could be an APRN program. We're looking at different creative models with CMS on that.
And both involve federal funding. If, God forbid, if we were to lose the federal funding, would we still be able to have these programs? How would we have to downsize? What would they look like if we lost a portion of it or all of the funding?
Chair, committee member Stacy Weeks for the record. Well, it's kind of a landslide. So if we did lose federal funding, obviously the efforts that we're trying to do here around GME would probably be affected. We would probably be taking those resources and not wanting to, we would probably be wanting to put all of this funding to maintain the program we have today. We wouldn't want to be taking it to do creative reimbursement models, for example. OSIT is state funded, is my understanding, and their infrastructure grants that are moving forward. Our hope is to look at matching some of that money and working with CMS to leverage more federal resources to get more out of that $9 million-ish that is in OSIT money each year. But again, if federal money goes away, all of that kind of, those efforts do fall, I think, to the wayside.
Thank you for that. Thank you, Madam Chair.
Thank you. Next, we will go to Speaker Yeager.
Thank you, Madam Chair, and thank you to you and your team, not just for being here today, but for being with us yesterday in a very late evening. Certainly appreciate it. I have a couple of different questions, and I guess the first one was just on the recommendations to keep, let me get to the right page. The recommendations to keep the 7 positions on that were ARPA funded. And so you touched on it a little bit. I think you talked about the pharmacists and how helpful that has been, and also the HR positions, getting your vacancy rate down to 8%. Could you just maybe give a little bit more detail on the benefit to keeping, I know you mentioned those 2, but the other of the 7 positions that are listed there?
Thank you. Jennifer Krupp for the record. So currently we are funding 1 budget analyst, 1 business process analyst, 1 information technology professional, 1 management analyst, and 1 personnel analyst, and 1 unclassified pharmacist 3, that is our statewide pharmacy director. A lot of the benefits that come from continuing to fund these positions, one, our state pharmacy manager or state pharmacist has been overseeing our state pharmacy program. She will be leading the implementation of the single PDL or preferred drug list that we had requested. She has also, will be leading some of the other critical pharmacy programs, including, the pharmacy benefit manager program and the implementation of the single preferred drug list. The budget analyst 3 is responsible for the oversight and the monitoring of the prescription drug rebate account. They're also overseeing a lot of the oversight of the hospital provider tax account that we're not talking about today. But the business process analyst and the IT professional have really helped assist the division with the successful maintenance and operations and components of our enterprise-wide IT system. So if we lose those positions, we're, at risk, just sort of across the division of not being able to conduct our day-to-day duties. And then finally, the management analyst 4 is responsible for the oversight of federal grants awarded to the division. And so that's a newer responsibility that we have overtaken since being able to bring this position on, but really having that leadership level position overseeing, the grants of those federal funds that we're bringing in. And then finally, the personnel analyst has been assisting quite tremendously with the timely recruitment and vacant positions within the division. I know Stacy had talked about it earlier, but just last year we were at a 28% vacancy rate that we've gotten down to 8%.
Thank you. And Chair, could I ask a follow-up on that? Makes a lot of sense. It sounds like those 7 positions have really helped. I did note in the materials, it looks like the governor's recommending $2.1 million to fund those positions, but only about $700,000 comes from the general fund. So I wanted to confirm the rest of that is federal money, and if that is the case, if we lose that federal funding, I assume we probably wouldn't be able to keep all 7 of these unless we were able to somehow supplement from the general fund.
Chair, committee member Stacy Weeks for the record. Yes, it would be at the landslide I talked about earlier. Thank you.
Thank you for that. And then, Chair, could I just ask one other question about the contracted dental hygienist?
Go ahead.
Thank you. So I wanted to ask about the E312 position, and I think originally the documentation we received indicated that that position was going to be funded through opioid settlement dollars. I understand that might not be the case, and maybe that was a mistake. So I wanted to ask if you could just clarify for the record how that particular position, the contracted dental hygienist in E312, is proposed to be funded.
Chair and committee members, for the record, Lynette Aaron, that is correct. So that was just a mistake, and it should not have been funded with opioid, and it's just Healthy Nevada funds.
Thank you for that clarification. I was a little confused about the nexus to opioids, and I was going to ask, but I'm glad to hear that that was just a mistake that was corrected. So thank you for the time, Madam Chair.
Thank you. I have a couple of questions, actually, kind of shifting. I know you covered a lot in your presentation, so I appreciate that. So I'm kind of moving to more of the health exchange and the HealthLink, the Nevada HealthLink eligibility determination. So have you received any confirmation from the federal government that the recommended system enhancements to move Medicaid eligibility to the Nevada HealthLink would qualify for that 90-10 match? I believe that there was we put in the request for that, but I don't know if we have any update on whether or not that has been approved.
Chair, Committee Member Stacy Weeks, for the record, we have had informal discussions with CMS officers on this, and it would be eligible, but we have to go through a very long process called an APD application. We do have that work underway, but we can't get a formal answer until we actually get this approved.
So when we're looking at this budget, I mean, it obviously includes the recommended, what we would hope we would qualify for, that 90-10 reimbursement thing. If it didn't, it would revert probably back to that standard 75-25. Is that correct?
Chair, Committee Member Stacy Weeks, for the record, it's hard to know. Depends on what they mean by 90-10 FMAP, if they're going to actually take the 90% off of technology. The discussions we've really been hearing have been more on the medical service side, but if it is technology, yes. But we would all be back here, I think, looking at our entire budget.
And that would be across the board for the entire Medicaid budget would be impacted if we went down to a different model other than that 90-10.
Chair, Committee Member Stacy Weeks, for the record, yes, we have a Gainwell contract that's very large. That would be a huge, significant budget impact. We have Deloitte contracts under DeWitt that would be impacted. There are a lot of 90-10, 75-10 contracts in the state.
Do you know approximately what the ultimate cost would be to our general fund if we had to maintain those contracts that we're already obligated, or are they obligated in such a way that they are dependent on this 90-10 match?
Chair, Committee Member Stacy Weeks, for the record, I'll have to follow up with you. I know it's in the billions. I mean, maybe I shouldn't say it, maybe it's the millions, sorry. My brain is tired after last night. I know it's big. I don't know if it's the B or the M, but let me follow up with you.
Well, if you're looking at this budget, it looks like it would be 32 million and potentially in the fiscal year 26 and 31.8 in fiscal year 27. So billions doesn't seem that crazy, unfortunately.
Chair, Committee Member Stacy Weeks, for the record, yes, that's over 2 years, but let us follow up with you because it's a different contract with Gainwell for services. They do a lot more than just enroll. This one here in front of you is just what we call the Medicaid Express. Kentucky has a similar model that we would be following. Other states are looking at this to make this easier, and honestly, if we are losing funding, have an automated system that works easier and is not so reliant on manual process might be most efficient. But let us follow up with you about Gainwell and other contracts for you.
Perfect. And then just to kind of stay in that same area, so there are other states, is Kentucky one that has applied and been approved for this 90-10 on this particular program about the enhancements to move Medicaid eligibility to the Nevada HealthLink? Is there other states that have been approved for this type of model?
Chair, Committee Member Stacy Weeks, for the record, I think we have to follow up with Kentucky and Virginia. I know they get federal funding. I just don't know how they did it with their exchange and what it looks like. What we're trying to do is set it up in a way where we would get the 90-10. We do have a small contract with a vendor to help us look at making sure that that is successful, and we're putting some of those items together now. But I'd like to follow up with my team and get you more information.
Thank you. Can you also discuss how the ongoing maintenance of the Medicaid eligibility through the Nevada Health Link would be funded going forward? I'm looking at some of the way it's currently suggested that it be funded, and it's using a lot of these, the money from the prescription drug rebate account. But it also doesn't look like, it's my understanding that in that account, for every dollar that we receive, we hold back about 2/3 of every dollar to send back to the federal government. And it doesn't look like we're holding back any of that money. So can you kind of discuss a little bit about how this would be funded?
Stacy Weeks for the record. That is a technical error that will be addressed, I think, in 3245. But the goal is to use some of the savings that we're bringing in with single PDL and other efforts to maximize our rebates to fund these first 2 years. If the Nevada Health Authority passes, we would also be looking at what opportunities to use any reserves that might be with the exchange to match those funds to support this effort.
I understand what you're trying to accomplish. Can you provide us, if you don't have them, and we'll have some more questions in this next budget around this, because such a significant majority of some of these enhancements are funded through this account that doesn't seem to have any of the holdback. And since it's such a significant part of the holdback of the 2/3, I'm curious to see what your predictions are for the savings that you would encounter making that shift to the one. It gives me a little bit of heart palpitations just because it's so much money that is unaccounted for that we would have to, again, account for because it's 2/3 of this fund.
Chair, committee member Stacy Weeks for the record. Yes, what we'll do is 3245 unfortunately is not before you today. That might have made more sense.
I think it's in March.
Yeah, so what we could do is in the meantime, put together the numbers for you and show you what we have, and we can talk about if there are things that need to be taken out.
I think that would be super helpful because saying it's a technical adjustment, it seems like too big of a number to be a technical adjustment unless there's some sort of corresponding evidence or proof that, or evidence that we are going to have such significant savings to be able to make up that 2/3 that should be going back to the federal government. And I just want to make sure that we don't end up with an even bigger hole moving forward. So, and I believe that budget is scheduled to be heard in early March. So if we can get some of that information, and I'm not going to lie, you'll probably see some more questions from our committee as we move through this budget, just because there's such a significant portion of some of these positions that are funded through that fund. Kind of in the same range, I know, what analysis have you conducted related to the number of eligible uninsured who may enroll in Medicaid if enrollment were automated through this? So you talked about how this will ultimately help with the automation and getting people going. Do you have any idea of how many people would be able to enroll?
Chair, committee member Stacy Weeks for the record. When we look at who is Magi, which we call Magi, these are people who typically should be eligible based on their tax income and tax returns. Magi is about 9% of the population. Our ex parte rate, which is automated or sort of trying to do automated today, is also high. So we anticipate anywhere between 80 to 90% of the population could be going through this system. Now, some people have documentation needs for citizenship. Also, there's, that would be different. They would need a caseworker to support them or some follow-up information. But we're trying to ensure that our Magi, which is mostly our adults, children, pregnant women, and families, would be automated. Anyone with a disability that has to go through the SSI process, or seniors who may have to spend down, who are higher income trying to get on Medicaid, they would typically still need a caseworker, which would be the other 10 to 20% of the population.
That kind of gets me, look, we're in sync here. You're answering all my questions. I guess that gets me to this next area where you're talking about how through this automated process, through the Nevada Health Link, we'll be able to, address essentially 80 to 90% of all these claims. And there would still be a need for direct social work services for that remaining 20%. what do you expect the impact? I mean, right now there are 1,827.51 positions, full-time positions in welfare that are dedicated to this. Do you anticipate a similar cut to those positions? Would those positions now be eliminated, all but 10 or 20% going forward with this new automated system?
Chair, committee member Stacy Weeks, for the record, no, because we haven't set it up yet. We don't know. Also, those positions do more than just Medicaid. They do SNAP, TANF, all the other items. So what we would want to do, because it's going to take at least 2 years or more to get this up, we would be working with DWIS and the Department of Human Services to look at attrition and not be looking at, like, our goal is not to have people lose their jobs. Our goal is to just make things more efficient over time. It's going to take time to stand this up. So as things roll out, we'd have a better idea for the next biennium.
So you anticipate it would take some time to implement this plan, so some of these positions would remain until there was a reassessment of the success, I guess, or the efficiencies that were gained?
Chair, committee member Stacy Weeks, for the record, I don't want to speak on behalf of DWIS or the department or director, but my understanding is those positions do more than just Medicaid. So we would be looking at not those positions. Our goal would be looking at our cost allocation plan to ensure that what we're funding them still aligns with what we need at Medicaid.
Thank you. And thank you for your patience with those questions. Next, we'll go to Majority Leader Canizaro.
Thank you, Madam. Thank you, Madam Chair. Scoot a little closer to this microphone. Okay. I have some questions to just relating to this streamline for the application period for Nevada Health Link. So how was it determined that adding functionality to Nevada Health Link was the appropriate path to address the federal eligibility rule requirements?
Stacy Weeks, for the record, there is a new federal eligibility rule that's focused a lot more on modernization and automation. And so beyond just that rule, when we look at other states that have been able to achieve this, it is an easier process. It aligns with what the Affordable Care Act wanted to do or tried to do with the No Wrong Door. When you're going to get health insurance, you have one place you go and you get determined eligible and you enroll. And so regardless of that eligibility rule, which is a new rule from the last administration, which we have heard could be removed and repealed, this still makes sense in terms of ensuring that any unintended stigma with individuals having to go to the welfare office or deal with sort of the welfare system in their mind, this might seem more like they're enrolling in health insurance. And also the managed care rule, there are some requirements that we allow our recipients to have what we call beneficiary support and counseling. And right now we do not have that. And so that is a compliance issue. This allows for some of that today that our DWIS eligibility workers are not able to complete.
So if that federal eligibility requirement changes, this would still be the recommendation from your department.
Chair, committee member Stacy Weeks, for the record, yes.
Okay. Was modifying the Division of Welfare and Supportive Services existing online Access Nevada benefit application portal considered as a means of complying with federal mandates to streamline Medicaid eligibility determination?
Stacy Weeks, for the record, no, because it doesn't offer the type of sophisticated system that you would see when you can shop for health plans on the exchange. That is not that way that system is built. And it would be building on our current system, which is, I think, more complicated. We know that we can get an easy tool through the exchange to do this.
Okay, so then would participants have to submit applications for services through the Division of Welfare and Supportive Services in addition to an application for Medicaid through the Nevada Health Link?
Stacy Weeks, for the record, no. And if they are eligible, the goal is if they're enrolling in Medicaid and they're Magi and they're able to get automated real-time eligibility determination and pick a plan, that they would be notified if they might be eligible for SNAP or TANF, and they can click to say, yes, I'm interested, and that file will be sent to our DWIS office, and then they would be able to process it.
So the way, just so I make sure I understand this, because, through DWIS, it's supposed to be a no wrong door. You're supposed to be able to kind of apply for multiple of these programs. This would be, they go in to see if they qualify for a Medicaid plan. Yes, they do. They pick a plan. and then they're informed you may also qualify for these other programs, that would then be sent over to DWIS. They would process that, or would the idea be that then they would reach out to that individual and say, hey, do you want to apply for these, or would that sort of count as the application?
Madam Chair, Stacey Weeks for the record. We would hope to have an interoperable system where the records could go over to DWIS without having to reapply. Right now, there is some additional burden in that process for enrollees.
Okay, thank you. And that's all I have for right now, Madam Chair. Thank you.
Thank you. Do we have any other questions on this administrative budget? Seeing none from the committee. Now, if you would like to take a break, or if you need, if you want to just jump right into it, we can start with the fun stuff on 3243.
Thank you, Madam Chair. Stacey Weeks for the record. So 3243 is our medical services expense account. Like I mentioned, it's federal funded, state funded, as well as county funded. As you can see there, most of the funds are federal, and the state general fund is a smaller portion of this bucket. Real quick, we have requirements to adjust the mandates here are just really adjusting for inflation that is required in statute for various services that we have, including our home delivered meals program. We are adjusting for inflation to address some of the food services through our waiver programs. The items here are just the adjustments to get our base in line, as well as any caseload changes that we had since the last biennium. I'm going to flip through these quickly because these are a lot of slides. So if we go to slide 34, that includes our juvenile justice coverage I mentioned earlier. We are required under federal law to cover children and youth who are in the juvenile justice system 30 days pre-release. Earlier, we talked about the staff that we would need to help support those children and youth as they're leaving the facility and coordinating care. This reflects their medical spend that we will now be covering. Indigent Accident Fund is also, and also, I just want to note that we are funding that out of the 3177, the provider tax program, because it does align with our efforts with the DOJ settlement agreement to support children that are in the foster care system or in the juvenile justice system. E250 is our indigent accident programs. This is just some of the funding. As you can see, there's some changes here to bring down more federal funds. Inpatient and private upper payment limit, these are other adjustments just to draw down more federal funds for these programs. The E252 is these are our provider tax programs as well, and they're tax funded. E253 is an enhancement of statewide coverage of school health services. When this was first implemented, and there's really, to the best of my knowledge, no state requirements around how it was implemented. When it was implemented, we made the decision that the counties could choose to participate. If that does not align with federal law, we have to ensure statewide-ness if this is a state plan benefit. It also, given all the decisions under court and case law since then, EPSDT, which is our children's benefit, is mandatory. And so when looking at this program, we decided that because we were out of compliance and we did not want to risk having to recoup money from counties and also paying back the federal government for all of this, we worked with them to come into compliance. This effort here is really making sure that we are funding all of these services statewide. If the legislature would like to make sure that the counties are paying for it ongoing, then we would need a mandate in state law to require all counties to pay for it. Otherwise, we would be out of compliance with this benefit. E254 is our single preferred drug list. This just shows here some of the increased costs in managed care. While there are costs associated with the single preferred drug list, like I said earlier, that brings in more in rebates to offset these costs, but also just want to note that as we grow some of the spending through managed care, this is also taxable by the premium tax, so it does generate state general fund. This item here is just some of our increased supplemental payments in our tax payment program. Some of these items will be addressed too when we get to 3177. We are doing our best. We are in the second state fiscal year of this program. It was implemented after session last time we met. This program has been successful, and honestly, it's been a great partnership with our hospitals, and everyone has paid timely, which has been really helpful for our cash flow. We are experiencing some delays on this program right now at the federal level. This came up last night, so just wanted to acknowledge that. Our hospitals are concerned about some of the payments. We are working with CMS and talking to CMS officials this week to see if we can get approval so we can get the state-directed payments out the door so we don't have any cash flow problems with the tax program. E-257 is our nursing facility supplemental payment program. Again, this one's paid by a tax that the nursing facilities pay. This one too is held up right now in review at CMS. We're hoping that will be moving here in the next couple of weeks as well. E-258 is some of the funding we're hoping to put into rates to really improve some of the and strengthen our mobile crisis system in the state. Assertive Community Treatment Services. This also is, right now it's a program that's primarily funded through DBPH, but we're hoping to create a different payment model to increase these services statewide. It's our ACT team program, or ACT services. This is being funded out of the provider tax payment program for behavioral health services. E-262 is our graduate medical education program that we're trying to stand up with some rebate funding to support our workforce initiatives around improved reimbursement for providers who provide training and GME programs. E-263 is compliance with NRS 422-27497 for ABA services. There is a requirement in state law that we adjust these rates automatically based on our quadrennial rate review. We have adjusted these rates up instead of cutting any, like last session we came forward. There were not that many reductions, but there were some that we just chose not to put forward. We are understanding last session that was not the intent. E-266, reimbursement reform for community paramedicine. This funds a new right now we have a community paramedicine benefit, but no one takes it up. And the issue there is that we do not have a viable reimbursement methodology for these providers. So often when we pass bills and we don't appropriately fund them, this is what happens. We have a service that should be really great and we're not able to use it. So we're really hopeful we can put money into this program. We're asking that we spend money out of the tax program. It does help with behavioral health needs and medication management. In other states, we've seen that be beneficial. We really think it would be a very helpful benefit too for our rural communities. E-267 is expansion of dental coverage for adults. Last session, we tried to seek approval from CMS for restorative services and coverage. It was Senator Neal's bill. That was denied at the federal level because they said we were not covering all of the services in the benefit, which prevented individuals from actually accessing the restorative coverage for free. And Medicaid is supposed to be a free program. So this session, we're asking to add in, to start with the preventative periodontal and diagnostic services. We also worked with Mercer on looking at cost effectiveness for this benefit, and it does save us money in our managed care program. So some of the updated fiscal analysis reflects some of those savings over time. E-268 is the new administrative cost that we need to get out to pull from 3177, which is our provider tax fund, to help stand up a new specialized managed care delivery system for children with behavioral health needs and our foster care kids. This is part of the DOJ requirements as part of the settlement agreement. This here would fund just the administrative portion of the managed care plan. So when you think of a capitation payment for managed care, there's two components. There's the admin spend, which is their overhead, care, case management, those care management, and then there's the medical spend. So right now we have mostly in our base all of the medical spend that we need as part of 3177 and also just different services that are already funded. We need help with funding the administrative pieces so we can stand up this benefit. Next slide is E-271, an increase to partial hospitalization services. This is a request to fund an increase in rates for these services. We did a quadrennial rate review and found that this was an item that needed to be improved. It also improves access for behavioral health care in the state. It's also part of our DOJ settlement agreement, and so we're asking to pull that funding, the state share, out of our provider tax fund, 3177. E-272 is an increase in rates to our day treatment services. This also comes out of our quadrennial rate review, and it is something that came up in many of our stakeholder conversations around children's behavioral health, as a lot of families need some of this day treatment service as well, and along with adults. E273, and again, these are all, just so everyone knows, the next few that are related to behavioral health are all out of 3177. If it wasn't for that provider tax and the state law that you guys passed last session allowing us to take the 15%, we would not be able to do any of this here today. So thank you. I just want to say that. The increase to inpatient psych and detox services. Originally, we came to IFC and asked for parity. We're asking for additional funding to give them an additional increase to support a lot of the increased needs we're seeing statewide in these services. E274 is a new benefit. It's not an increase. It's really creating a first episode psychosis treatment program. Other states are creating this program, and it's really helpful for some of our children with behavioral health needs. So we are also asking that comes out of 3177. Next slide, the last one of that bucket for 3177 for now is our increases to behaviorally complex care program. This is that skilled nursing facility program I mentioned earlier. This is the bonus payment that would be based on quality and ensuring that these providers that receive this funding are working closely with their local hospitals to transition individuals who have complex and skilled nursing facility needs, but also have complex behavioral health needs, that there is an avenue for them to have a bed. Often they are stuck in our hospital system. E900 and E500 is that graduate medical education program. This is just the transfer of the OSIP funding over to the Nevada Health Authority, as we talked about earlier. Real quick, I just want to do, for some of you who maybe weren't at IFC and maybe we haven't talked about the DOJ settlement agreement, over a year ago, it's been almost 2 years, or a little over now, the state was found out of compliance with the Department of Justice, ADA, the Americans with Disabilities Act. The DOJ said we were currently not providing adequate services in the community through our public programs. And so these individuals, these children were forced, and these families were forced to really put them in institutional settings, which violates the ADA. So Medicaid needs to cover, just as much as it covers institutional care, it needs to cover home and community-based services. So as part of that agreement, these are all the services here on this table that we are standing up and that we're focusing on right now to comply. So as you can see, some of these were already approved by the body at IFC. We are working to get those up. We are working with CMS. Some of these things we're waiting on CMS to give us feedback. We're also looking for the appropriate federal authorities. We may need a waiver for some of these items. But we have a full team, thanks to this funding, that is really lifting this effort. I will say that I'm very proud of this work. I think our team, I know there are people that have been working on this for decades, and I feel very happy that we can be able to support their work and actually bring this forward. So these items are part of that agreement. All right, I'm going to stop there, Chair. I'm sure there are questions, and then we'll go to checkup.
Thank you. It's like a second language, this budget for you. So I appreciate you sharing your knowledge with us. But before we get to some of the individual member questions, I'm wondering if you can address what your anticipation is when, in addition to the loss potentially if the hospital provider fee is not renewed, and you haven't heard anything yet about whether or not those payments will continue. I think you indicated that you would have to stop making payments to those hospitals in April.
Madam Chair, Stacey Weeks for the record. We would like, right now, we have, so let's to help answer that question. So, we're in Q3 of the state fiscal year. We currently paid out 2 UPL payments. We paid the fourth quarter UPL payment early to help address the state-directed payment. Now we're facing Q4. If we don't have approval, which we have to have for state-directed payments, we have to have an annual approval of our preprint. If we don't have an approval in the next few weeks, we will pause the program. So we are not collecting a tax that we cannot pay out on.
And obviously, we're looking at here, and for the members, this, to be in compliance with the DOJ settlement for these kids that we have been out of compliance with, a majority of the positions and programs that are funded in this budget that we're talking about today are funded directly with those funds. At what point will your office have to have this discussion? When you pause those payments, is that when we are going to expect to see significant cuts to all of these programs that you're proposing to expand today?
Madam Chair, Stacy Weeks for the record. I am hopeful, based on my last conversation with CMS, that we will see something in the next few weeks that we will not have to cut these programs. But I cannot guarantee. I feel like we're all in this position right now, and it is very challenging. What we have in front of you is what we hope, and if we get any indication that they're not going to approve it, then yes. My understanding right now is just on a slower track, which causes us to be in the position of not being able to tax anyone for a while until we get it approved. But I can keep this body updated when we have our conversation with CMS, if that's helpful. But yes, all of these programs are tied to that funding, and it is the only reason I'm sitting here today, and we're not in the same place that other states are, where they don't have the funding to support their DOJ settlement agreement.
And do you have the overall number that our state, just even in the first year of implementing this provider fee, that 15% that has come back that we are able to utilize for children's mental health services and these other things, what that amount is to our state?
Madam Chair, Stacy Weeks for the record. For state fiscal year 26, we're anticipating $59 million in revenue for the children's behavioral health.
And so if on the off chance that this was not approved, we would be looking at filling that $59 million hole and not being able to comply, or continuing to not be in compliance with the DOJ settlement.
Madam Chair, Stacy Weeks for the record. Yes, we would not have the funding, so we would not be able to move forward with those services. Under the agreement, though, there is a provision in the agreement that says if the federal government goes back on its agreement for federal share, that we can get out of that agreement. But it doesn't mean that the children in our state won't suffer for that.
Okay. And in addition to the impact on the state general fund, what is the impact on the hospitals that are providing these services and taxing themselves voluntarily to participate in this program?
Madam Chair, Stacy Weeks for the record. Well, the program, the state-directed payment I'm talking about for calendar year, because it's hard because state-directed payments are based on calendar year, not fiscal year. But the entire program for the calendar year is over $1 billion. It's about $800 million in federal funds.
And so if those hospitals were not getting those nearly $1 billion, we could expect to see also cuts to services that they're providing.
Madam Chair, Stacy Weeks for the record. I don't want to speak on behalf of the hospitals. I don't know how they would respond. I think with this program, if it is significantly changed, we have to go back to them and ask them, do you still want to have this program? Because it was a voluntary survey. And if they do not vote, the majority of them, if it's not worth it, then it does go away. And that's the decision I think that we all face in the state of having access issues.
Thank you. And thank you for your candor with those responses. If we could next go to Assemblymember Howdegui.
Thank you, Madam Chair. And I want to ask about the methodology for Medicaid payment projections. I know that the executive budget for the 25-27 biennium included changes to the methodology that we had approved in the 23-25 biennium for projecting costs associated with very low birth weight, stop loss, and maternity payments. And I was just hoping you could give us some more insight as to why the agency has chosen to use the 3-year average methodology to project low birth weight, maternity, and stop loss payments, rather than the prior approach of forecasting individual occurrences based on anticipated cost.
Chair and committee members, for the record, Lynette Aaron. At the time when we were building the GovRec budget, we didn't have the information, the reports for those very low birth weight, the maternity kicks. And so we did build it off of a 3-year average. Since GovRec, we did do an analysis, though, looking at the actual count of, like, for example, the very low birth weight and maternity kick. We did provide that analysis to the LCB. I don't have those numbers with me right now, but using the prior methodology for some of them actually increased costs for Medicaid. I believe the maternity kick payments, so that was the only one that it did lower costs using the prior methodology.
Okay, thank you. So you won't be submitting any amendments. You're going to go with the 3-year average.
Chair and committee members, for the record, Lynette Aaron, we are still considering it at this time, whether or not we will move forward with a technical adjustment or not.
Okay, thank you, Madam Chair. May I have a follow-up? Okay, thank you, Madam Chair. My next questions are relating to the budget amendments that were submitted to correct the errors in the governor's budget relating to the waiver and county indigent Medicaid cost estimates. The first one is, does the agency believe that using cost per eligible data from July to December 2024 provides a sufficiently accurate basis for projecting the true cost for waiver and county indigent Medicaid eligibility categories?
Chair and committee members, for the record, Lynette Aaron. What I would say with that is that it's the PMPMs is moving, month to month. The December 2024 numbers would be more accurate to what we're seeing as opposed to like what we had presented during the agency request budget. I will say, though, that it is the division's intent to look again at those PMPMs during the updates when we do inflationary updates as well as FMAP, but then to look at those PMPMs because we have been seeing an increase month over month in that.
Okay, and with that, can you confirm that all the increases to the county revenue included in the submitted budget amendments fall within the statutory maximums outlined in NRS Chapter 428?
Chair and committee members, for the record, Lynette Aaron. At this time, it's hard to say. Typically, those maximums, we don't get that information until we receive it from the Department of Taxation, so we receive estimates. I'm assuming you're referring to the 8%, 8 cent cap. I will say an analysis of the prior fiscal year, that was about like $2 million that we did pay on behalf of the counties that went over that cap, though, so it is a small amount.
If I could, Madam Chair, one last question.
Go ahead and keep asking.
Okay, thank you. My last question is managed care quality incentive payments. So how is the Medicaid managed care quality incentive payment program structured? And what is the projected financial impact of these quality and incentive bonuses to this upcoming biennium?
Madam Chair, Stacey Weeks for the record. We can follow up with more information on that.
Okay, because I don't think I saw any impact. So does that mean they're going away?
Madam Chair, Stacey Weeks for the record. They are not in this budget, yes.
Are these quality incentive payments, are they incorporated in other areas or did they just go away completely?
Madam Chair, Stacey Weeks for the record. So this is a historical issue. So there are quality withholds in our program that continue. So we do hold the health plans accountable for a quality withhold, and that is continuing. We are at the end of our contract period, and 2 or 3 years ago, I'm forgetting my years, there was a major rate cut that our actuary recommended. It was 9%. And if we had let go forward with that, I'd be sitting here in front of you with a much bigger hole than I have today. We pushed back on our actuary. The MCOs pushed back. We got down to about 6%. And then it got down to 4%. And all I could do was a quality incentive bonus payment to get them to sign the rate setting requirement. And that is why we have a quality bonus payment program. It was tied and so to get that rate increase that they needed to sign the rates, because if they didn't sign the rates, I didn't have any plans. So to get them to sign those rates, I had to offer 2% and a bonus payment. And we had the funding. We were funded for much higher rates. And when I did that, we tied it to primary care spending. We tied it to value-based payment design, and they had to meet metrics to get that funding, more than they have ever done. And they met those metrics, and it worked. It was a carrot that I haven't seen work before, so it was nice. But as we sit here today, we are not anticipating any bonus incentive payment programs for the next biennium. That was a deal to try to get us through this massive rate cut during COVID. We had all these non-utilizers on our program who were inflating and not really affecting our risk pool. And then now here I am in front of you with a 6% rate increase. So if my actuaries, right? So this is the reality I live in Medicaid. So that bonus incentive payment program was built into our last budget. I don't think we'll have funding for one. I don't know. I think the rates are going to go up, obviously, and that's why we have inflation. And I want to talk about that too today, about an inflation issue in our budget.
I know we have some time and we have some questions around the inflation issue. So you don't anticipate that you are going to run into these same issues with negotiating? You said you're at the end of the contract, so I'm assuming you're going to head into this same situation again. But do you feel like we are in a different situation post-COVID that you will be able to negotiate without these bonus payments going forward?
Madam Chair, Stacy Weeks for the record. Yes, I think we're not going to be looking at a 9% rate cut again.
I'm going to kind of go back to something that Assemblymember Hadigi asked about the county revenue included in the submitted budget amendments and whether or not they fall within that statutory maximums. And I know that analysis hasn't been completed yet. Do you anticipate when that will do? And have you started to have those conversations with what this impact would be on the county? It looks like it would be around $44 million that the county potentially, that's a pretty huge impact on the county. So I'm wondering what kind of conversations you're having when you anticipate that analysis will be completed.
Chair and committee members, for the record, Lynette Aaron. So we would typically have that information when the year starts, the fiscal year starts, so in July. But just to kind of give background, so when the agency request budget was set up, it didn't include those costs that should have been assumed by the county, so it actually was underfunded for their revenues. Right now, for fiscal year 24, for example, the counties, we are collecting over like $50 million for them. So I believe our governor's recommended budget with the amendment is up over 60 million, which is more in line with what we're seeing right now.
Thank you. I think the next question we have is from Assemblymember Brown May.
Thank you, Chair. Thank you. It's so good to see you again this morning. Thanks for being with us last night and again today. If I could, I'd send you a donut. I would like that. I have questions about the waiver caseload. And I'm confused a little bit, so I'm hoping you can provide some clarity. It looks like the governor's recommended budget is $92.5 million over the 25-27 biennium to address caseload growth. It doesn't look like it addresses wait list. It's my understanding right now that there is a freeze from the providers, right? We're not able to bring new folks into services currently because of the way we budgeted last cycle, and that perhaps a rate increase was not appropriately accounted for. I'm curious to know, are we addressing that in this budget that you're aware of? And why are we not looking at wait list? I don't know that you have these answers, right, because they're coming out of ADSD. Are we not looking at wait list? Are we only looking at caseload? And have we now met what we thought we did with a rate increase last session?
Chair, committee member Stacy Weeks for the record. I think Dina Schmidt would be the best person to ask that question to. So, yeah.
Thank you. I appreciate that. Thank you, Chair.
If we can also pass on a message to Ms. Schmidt, I'm looking at this recommended budget and that 92 million. It's just such a huge jump, and I know that we have issues with this one every session, I think. And I'm not sure why, but this budget is almost all federal pass-through money. Is that correct?
Madam Chair, Stacy Weeks for the record. Are you talking about our 3243 or ADSD budget?
The ADSD budget. I'm sorry, the recommended. I'm trying to figure out. See, all the numbers are coming together. Yeah, the waiver caseload.
Madam Chair, Stacy Weeks for the record. I would have to follow up with Dina, but yes, they receive a lot of federal funding through Medicaid. under our waiver that we have with the federal government to fund home and community-based services. It also funds staffing at the ADSD.
I'm just curious, and if we can get this message back to Ms. Schmidt, because it appears with that $92 million in recommended expenditures and the caseload growth of only 118, that is the equivalent of about $80,000 per month per person. And that seems like that doesn't seem like a right number.
Madam Chair, Stacey Weeks, the record. We'll definitely follow up with her and make sure you get that information soon.
Okay, if she could contact our staff, just because I imagine that seems a little off. Like I said, $80,000 per person per month is, I don't know, it seems high. And with that, I think the next person that we are going to is Assembly Member Yeager.
Thank you, Chair. I have a few questions on M101, the mandatory rate increase. Hopefully these questions will make sense. These budgets are admittedly pretty complicated. But I noticed on that particular, in M101, there was a budget amendment that was submitted 4 days ago that has additional general fund of about $66 million for projected inflation. And so my question was, I didn't see a budget amendment that offset general fund decreases or general fund revenues. So could you give us some information about any solutions that are being considered to offset that $66.3 million?
Madam Chair, Stacey Weeks for the record. So yes, so in our budget, there was an error. I'll talk about it now. It was at the end, but we'll recap there too. There was an error that we discovered, and thanks to LCB, I don't think anyone caught it until the last few weeks, and it did not include inflation for our managed care program, which is a big deal. And that has left us with another hole, right? So we do have some items to address that we were going to talk about. One of them is some savings from what we're doing with Paris data matching, which really allows us to automate the system that we have today through a vendor that we have where we can check people who are out of state faster and get them off our program faster. It does save us money. It's part of the LCB audit too. So thanks to them for pushing us on this because it brought us some savings. The other item that we are looking at to help fill the hole would be the
I'm sorry to interrupt, Ms.
Yes.
Weeks. Is there any way you can kind of
Go to that
break
slide?
it? No, we'll go to the slide too, but also maybe I don't remember if it breaks down where some of that money is coming to fill that new structural deficit.
Madam Chair, Stacey Weeks for the record. So as you can see here is the breakout of the inflation budget amendment that we have submitted. There is a state general fund in 2026 of $23.8 million, 2027 $42.5. We are working on several adjustments and amendments to bring forward to address this inflation. As I've noted here, they are in progress. I mentioned the automation of Paris data matching, which we think brings us about $10 million each year in savings for our program. We're also looking at paying our July payment for capitation payment rates with some of our surplus that we have now. It's about $43.9 million. We're paying that early to help reduce the costs over the biennium. We do have a caseload adjustment that we're looking at. Due to some of the new immigration policies at the federal level, we have seen and we're hearing from our providers that individuals are not coming in for care. And we also know in the past when we had public charge, nationally we saw about 30% of people come off Medicaid rolls. So we will be submitting an amendment to adjust caseload and looking at immigrants and looking at trying to be conservative about it over time, but we're looking at potentially over the biennium a 10% reduction in that population, which we do think does fill this hole and a little bit more, but we are finalizing those numbers and would like a little bit of time to get those ready for you so we make sure that they are accurate.
Chair, could I ask a couple other questions?
Of course.
Thank you, Ms. Weeks. And you may have covered this in what you just said, but I just want to make sure we have it clear for the record. So that same mandatory rate increase M101, it looks like there was a change in methodology that removed the caseload growth component from the inflation calculation, which I think actually resulted in general fund appropriations that were increased rather than decreased. And I think that was for the fee-for-service inflation. So you might have covered this, you might be working on this, but if you could talk about that change in methodology and the reason for doing it that way versus how it was done in the prior fiscal year.
Chair and committee members, for the record, Lynette Aaron. So that change in the inflation formula under the fee-for-service, so what I would say to that is when it was done in the prior biennium or the biennium we're in right now, the 23-25 biennium, it does include in that formula the caseload for, at the time that would have been our base year, which was fiscal year 24. And I do believe that there was an error in just how that inflation formula was set up, because in 23-25 biennium, because caseload was increasing, that actually added more inflationary costs, right, for that decision unit. But now that we're seeing with the unwind, right, our caseload is actually decreasing. So when you're taking into account that caseload from fiscal year 25, it's actually a negative percentage. So that's actually driving down the inflationary costs. So using that prior methodology from the prior biennium would actually understate the general fund costs for this biennium. So with our governor's recommended budget, we did make that change and update it to remove that caseload percentage. So it does actually show that with the inflation year over year changes, that it's actually increasing, which is what it should show.
And Chair, I have one more, if I could, on that same M101. And this one is about the fee-for-service rates. So have you calculated the fiscal impact of the new requirement for managed care organizations to reimburse providers at a minimum rate equal to the fee-for-service rate across all Medicaid services?
Madam Chair, Stacey Weeks for the record. Yes, when we build rates for managed care in Nevada, we include all the fee-for-service rates and the funding as part of the capitation payment. So those rates do right now reflect that money. We just have no authority right now to ensure that MCOs are actually paying the fee-for-service rates. We do anticipate that most do. When we talk to providers, when we raise our fee-for-service rates, they are also, most of them do raise theirs. In the new contract period, we are asking that they at least hit the fee-for-service schedule, because if we're putting that money in their capitation payment, we want to ensure that they're actually paying the fee schedule at a minimum.
I think we next will go to Senator John Darrell Loop.
Thank you very much, Madam Chair. I am trying to process these questions as we speak. All right, so thank you for being here as well. Can you indicate why the governor is recommending managed care rate increases for community paramedicine, partial hospitalization, day treatment, and inpatient psychiatric and detoxification facilities starting July 1, 25 to January 1, 2026.
Stacey Weeks for the record. They should not just be one time. They should be ongoing. So if that is what you're seeing, then we need to do a technical adjustment to that.
Okay, yes. I mean, I understood it that way. So if you could clarify for me, that would, or for all of us, that would be great. And will the state incur increased managed care expenditures then between July 31, 25 to December 31, 26 as a result of these rate increases recommended for community paramedicine, partial hospitalization, day treatment, inpatient, et cetera?
Chair, committee member Stacey Weeks, the record, no, because we have no way to enforce the MCOs actually follow the fee schedule, so they don't have to, and they can continue to pay what they want. But often they do if they have the room, so it's their choice. But we're not anticipating any increases to the rates for the last 6 months of the year.
Okay, yeah, I'm starting to, some of the stuff that I've thought about as we've heard some of your information is our rural communities and how that might affect them. You know, I am very cognizant of the fact that, right, most of our state is rural. So we have to be aware of that. Madam Chair, may I keep going? Thank you. Can you also discuss that proposed rate methodology reform that's recommended for community paramedicine services and the anticipated impact to service availability throughout Nevada?
Madam Chair, Stacey Weeks for the record. On the community paramedicine, we're looking at a higher rate that we're based off Arizona and trying to make it simpler, more like a bundled payment. But we can follow up with the actual codes and rate increases. It's pretty significant, and we are hopeful that it actually will have an impact. But we can follow up with the committee with the actual information from the fiscal analysis.
Okay, and then can you, for the $500 daily rate for partial hospitalization, what analysis was used to support or justify that?
Madam Chair, Stacey Weeks for the record. We used our quadrennial rate review to help us try to come up with a number that we thought was reasonable within the region.
So it's finding a reasonable rate. Is that what I'm understanding?
Madam Chair, Stacey Weeks for the record. It's a little bit of both, right? So in our budget, we have to consider how much funding we have in the provider tax fund. And then we have to look at regionally how far we're off and trying to thread a needle. And so that was the number. But I can follow up with more detail about how far off our rates are compared to other states in our region. So if that's helpful to see if you think that this rate is enough. But we were also trying to stay within a reasonable amount under our provider tax payment program.
Okay, I just was trying, when we hear, this is your wheelhouse, right? And so when we hear all this information and we're trying to understand, and so I was just trying to understand if it was just sort of and I don't mean random, but random $500, like this will work, or whether there was some actual data put into it, or whether you had a cap of 500, or, how that all came about.
Chair, committee member Stacey Weeks for the record. In this case, we looked at the quadrennial rate review in other states and did our best to put more money into it to try to get closer to other states. But let me follow up with the differential for you so you have it.
Okay. All right. Thank you. And thank you for being such an expert in this field, because this is all really important to the state of Nevada. I appreciate that. And thank you very much, Madam Chair.
No, thank you. Sorry, I had some questions about that too. You see all these rate increases and it's usually like some random number. And then these two rate increases, it's like $100 and $500. So I was wondering about that methodology as well. Chair Mosca.
Thank you so much, Chair. I have a couple questions. Thank you. I have some specific questions. So first on 272 for day treatment, can you please provide the context and background related to the estimated per participant cost? Because of the rate increase, it looks like it totals $28,378 per patient in FY 2026.
Chair, committee member Stacey Weeks for the record. I don't have that fiscal note and analysis here in front of me. I'll have to follow up. If you guys want to send some of those detailed questions over, we can dig into some of that for you.
Okay, thank you so much, and I'll just say the rest of them just so we have them. So the second one was on the inpatient psychiatric and detoxification facilities on E273. Without knowing the impact of the previously approved rate increase to $944 per day for psychiatric and detoxification facilities, how did the agency determine an additional rate increase to $1,250 per day?
Chair, committee member Stacey Weeks for the record. During IFC, based on how much money we were able to bring in for the provider tax payment program and the issues we've seen with our psych hospitals and even keeping beds, we knew we needed at least do parity. Because right now, before we did parity and at IFC in April, the detox and psych hospitals were getting less than what someone would get if they went to a hospital without the inpatient psych facility setting for the same service and same patient. So we at least needed a parity. So that was the first step. And now, even after parity, we're still hearing from a lot of our hospitals about closing beds. So we think that a rate increase is really important. And it also aligns with the statutory authority that we have to spend this funding to support hospitals and ensuring that they have the funding that they need to support people with behavioral health needs.
Thank you, and as my colleagues have said up here, we really appreciate you and this expertise. So my last one is on the skilled nursing facility quality incentive payment, E275. If you could discuss how facilities participating in the behaviorally complex care program would be eligible for bonus incentive payments, and what associated measures would be used to measure facility success.
Thank you for that question. Stacey Weeks for the record. Currently, this program is a tiered program depending on the level of need that they take, skilled nursing facilities take for people with behavioral health needs. What we would want to do is create a program where facilities could apply for this new quality bonus payment, and they would have to apply and say that they would be bringing forward a care coordination agreement with their local hospital or hospitals, that they would be sort of that space, so that way when someone needs a bed and they're stuck in the hospital and they need skilled nursing facility care, but they're complex, that the hospital actually has a placement. We would also be putting in metrics around how long it took, right? What is the quality of care that individual's receiving? So part of our funding request here is to really build out the metrics that we need and to have a staff individual oversee that program. But we do believe this program is successful in supporting our hospitals and our communities with some of these more challenging needs that we have. But having this quality bonus payment, I think, really will help do more between the skilled nursing facility and the hospital, which sometimes they're not talking and don't realize that they both have the same need and there's funding there to help them. So we're hoping that this will really highlight this program and expand it.
Next, I'll go to Senator Titus.
Why, thank you, Madam Chair. Thank you for allowing me to ask a couple questions. First and foremost, thank you for being here. Thank you for your incredible understanding of a very complex system. And it's been that way for a long time. I also want to acknowledge how important it is in the rules for that travel fee that you're allowing so many patients. Telehealth is great, and you can get in your community, but there are many times you have to travel to a provider at long distances, and that reimbursement is huge. I also want to thank you for the acknowledgement in fixing the dental programs. I think the good oral hygiene leads to good general health and cost savings overall. So those are my thank yous. Now, I have a couple questions, if I might, Madam Chair. So my first question is, you've given us some good pie charts and some graphs. On page 11, you showed a pie chart of the enrollment and who is enrolled in Medicaid and the spending per that. And then on page 30, you give us a graph of the payments going out and how what funding sources are used. But is there some way you can get us, and I looked through all of this and I don't see it, how the payments from Medicaid go out based on the services, so we know what services are the most expensive, those type of thing, and what providers, because there's a mix here. You have MCOs that get paid per enrollee, and then you actually have other services that you pay directly, not through an MCO. And so it's very, again, convoluted on that payer who you pay out. And so if we could get, because again, I don't see it, and so I'm sure you have it, what provider types are, some sort of graph on here we're spending the most money here, the MCOs versus travel versus dental. So that would be very helpful.
Chair, committee members, Stacey Weeks for the record. I'm glad you asked that question because I think we have something like that already, but I think we need to dive a little deeper into it because you're absolutely right. There's different types of spending to providers, but it's also important to understand the category of service that's being funded the most. The third of our spending right now on medical services outside the supplemental payments is on professional services, so physician, so 30%.
That's not through the MCO program, that's directly to providers?
Madam Chair, Stacey Weeks for the record, it's both fee-for-service and managed care.
Right,
so we can break that out as well. So what I will do is I'll look at some different options to break out the spending and send it to this committee. And if it's helpful, we can present some of that next time as well. I do think it's important to understand as well, like where this money goes and which providers are getting paid more and sort of, so as we understand spending in this program.
Right. Follow-up question, Madam Chair? So now a total different thing. the provider tax. So not all provider tax are created equal. I mean, you mentioned, I think I just need some clarity. The provider tax, it's a 15%. Providers all had to pay that, but not all providers get paid back the same. Is that not? There's winners and losers in that program, correct?
Madam Chair, Stacey Weeks for the record. Yes, there are winners and losers, but luckily we've been able to maximize the tax. With Mercer's help, we have come up with a model, and the hospital's help, with a model that really, in our state, limits the losers. And if they are losers, it's not as big as what we might see if the tax gets lowered at the federal level, and that we have a different limit. Right now, we're maxing it out at 6%. But overall, this program is very beneficial to the recipient, to the hospital program. Mm-hmm.
Thank you. And along that same line, Madam Chair, if I can continue. So I think what I see is, what I've heard from you, and I just need clarification, that at this point in time, there has been X number of dollars that these provider taxes, they've been paid. And I think last night it was mentioned also that there's a pot of money that's been paid out, and they, under the Biden administration, that was kind of halted. There's been a delay. Is that what I heard? And so there's still, now we're just trying to catch up with that. Is that not correct?
Madam Chair, Stacey Weeks for the record. I would say that the pause happened under the new administration. We have been waiting longer than normal, and at one point finally did hear back that we will have a call, hopefully this week, with them about this preprint, but that is the delay. It's with the new administration.
Right, so it was current, because I thought I heard last night that there was a pause earlier and you were just trying to catch up.
Madam Chair, Stacey Weeks for the record. No, I apologize if that was a confusion.
Okay, thank you. And then finally, one last thing, would you at some point, I mean, everybody's throwing out that we're trying to make up some of this voids under the areas of fraud and abuse, but I don't see where those are the most identified areas of fraud and abuse. I mean, it's easy to say that's how we're going to do this, but what I'd like to see is in the past, or what are we looking at? And that's why I wanted to see who's getting paid the most and what areas are subject to that susceptibility of fraud and abuse, because I think we need to really be able to hone in on that.
Madam Chair, Stacey Weeks for the record. I'm really glad this is a conversation and I can provide you guys with some details. I mean, high level, we can't talk about actual cases, but high level, which areas we see the most fraud and where we're seeing more sophistication. I will say pharmacy has become a very sophisticated level of fraud that we need specialized expertise to keep up with. AI has made this also more complicated. For us. So, and being able to act quickly when we find the fraud, because often if we've paid a provider and they get criminally charged, it's really hard to recoup that money, to be honest with you, for the state. Mm-hmm.
Thank you for that. So really some take-homes is provider payouts. What have we identified in that fraud and abuse potentials? And that, I think it's related to who you're paying out and what categories they are. So thank you for that. And maybe follow up on that and that the tax on the providers, I think, information on that. So thank you, Madam Chair, for the questions.
Do you have any others? No. Okay. Just kind of following up on this, I want to make sure, I had the opportunity to kind of look at some of the actual fraud cases, and with the millions of claims and things, it appears that the majority of those fraud cases are on the provider side. Is that correct?
Madam Chair, Stacey Weeks for the record. Yes, that's where the money is the biggest.
And I believe there's only 10 cases that have been, I guess, adjudicated and determined to have that fraud. Is that correct?
Madam Chair, Stacey Weeks for the record. When it comes to that side of the house, yes, but the reality is there are a lot of other cases that are ongoing, that are confidential, that are under FBI or criminal. There's also the reality that we end up closing a case before, if we can't get that support, that there is fraud, because we feel the risk is too big. So that's the challenge that often we have.
And again, this is mostly where you're seeing it is on the provider side.
Madam Chair, Stacey Weeks for the record, yes.
I just want to distinguish. I know that a lot of times there's this misconception that it's a bunch of people scamming Medicaid, but for the most part, it is on the provider side. It is not on the participant or consumer side.
Madam Chair, Stacey Weeks for the record. I don't have actual data from DWIS, but I know nationally that is true. Also, just besides the Medicaid and Medicare, this is often where provider fraud is ripe.
Thank you. Next, we'll go to Assemblymember Monroe Moreno. And I believe she has a couple of questions.
Thank you, Madam Chair. And switching gears, going to the applied behavior analysis rate increase, the E263, and the question might be, Ms. Weeks, you're amazing, but the question might be better answered that I have my first question from either the governor's office or the GFO, and that's NRS Chapter 422 requires that the director of the Department of Health and Human Services to, among other things, biannually establish rates for applied behavior analysis services compared to rates of reimbursements paid by Medicaid programs in other states. And then last session, in the back language, we as a body put in the Appropriations Act that only funded changes to applied behavior analysis rates which would increase relative to other states. However, it appears, and I could be wrong, that the recommended change in the budget from the governor's office is in conflict with that statute. So could someone just confirm if the governor's recommended budget for the applied analysis rates align with the statute as written?
Madam Chair, Stacey Weeks for the record. I would be able to answer that. Yes, it should, and if it doesn't, we will fix that, but it should be all increases.
Perfect, thank you. And like I said, you were amazing. You didn't need to phone a friend. So, Madam Chair, as you said, I had a few. So my next questions will be for the service expansion, E258, 260, 267, 274, that whole group. Could you tell us or indicate why the governor is recommending the rate increase for the mobile crisis assertive community treatment and the first episode of psychosis service expansion to begin in on July 1st of 2025 as opposed to January 1st of 2026?
Madam Chair, Stacey Weeks for the record. I think we're trying to implement them as quickly as possible because if we can get the state plan amendment in timely, we can often backdate. So the funding can go back. If we did January 1, we wouldn't have the opportunity to even backdate even to October. So this allows us the opportunity to backdate with CMS, the funding.
Perfect. Thank you. And then my last question, Madam Chair, is will the managed care organizations change their level of coverage benefits starting on July 1st to add the mobile crisis, the assertive community treatment, and the first episode psychosis service expansions?
Madam Chair, Stacey Weeks for the record. Yes, so we are currently, I hope soon, announcing the winners of the procurement. It's the new contracts start January 1, 2026. We do rate setting with our actuary at the end of the year. So whatever passes this session, we will be building rates to include that. So any funding that we get for these items would be in our base to pay for those capitation payments.
Thank you, Madam Chair. And thank you.
No, thank you. Next, we'll go to Assemblymember Hadeke.
Thank you, and I think you answered my question, and so I'm just going to state it as a statement, and you can just nod. But so then the juvenile justice and first episode psychosis services will be implemented by that July 1st, 2025 date, correct? It sounds like you guys are trying to get it off the ground as soon
Madam
as
Chair,
possible.
Stacey Weeks for the record. We'll do our best, but having an earlier start date allows us to backdate payment. So when providers get it, we get it approved, we can also pay back any claims up to that date. So it allows us to at least get the money sooner, but all of it relies on CMS. So if I had a crystal ball for CMS, I would keep it close.
Thank you. Madam Chair, just a couple follow-ups, please. Okay, and then I just have a couple questions regarding E258. I know we're looking to expand the 24/7 mobile crisis service. So my first question is, can you just give us a little bit more background into the per member per month component of the recommended mobile crisis service expansion, and if the agency has received federal approval for the proposed reimbursement methodology?
Madam Chair, Stacey Weeks for the record. So we don't look at reimbursement rates typically on a per member per month basis. This is based on a we're looking at a tiered rate is what we're trying to do. So right now what we have is a rate that just really would be supporting an enhanced model, which we obviously would love to see statewide, and it requires 24 service, all the things. But what we're hearing from a lot of our mobile crisis providers is that they're not ready for that. So the rate payment that we have now won't be actually accessible. So this would allow us to create a step down tier where we can provide some payment. It may not be for the higher enhanced mobile crisis rate, but it would be a lower payment, but at least some funding to pay for the services that they are able to provide in their community if they can't have a 24/7 individual on call. So that is the goal of this rate. But I can follow up more detail if you want to see the actual rate increases and pieces like that.
And Madam Chair, just one follow-up on this. And Ms. Weeks, just sticking to the mobile crisis, I know that the final rates and the funding model are dependent on a vendor review. Do you guys have a timeline for that vendor review?
Madam Chair, Stacy Weeks for the record. Yes, so we currently have what we call our mini waiver list and statutory and authority list, and we would be leveraging from one of those three vendors to support us or the MSA, so we can move quickly on this.
Look at this. Assembly Member Brown May.
Thank you, Chair. Thank you. I have questions about E260, the Assertive Community Treatment. I don't know this program. Is it new? That's my first question, right? Like, this is not familiar to me, and maybe I've missed it before, but surprise. And then, like, it's funded at $25.6 million over the 25-27 biennium to support what looks like 540 patients, which seems like a really high cost. Is it new?
Madam Chair, Stacey Weeks for the record. No, it's not new. Right now it's called the PACT program at DBPH. A lot of states have ACT teams that go into the community and support individuals who have really serious behavioral health needs. This is like schizophrenia, other really complex needs to help them live in their community. That's why it is expensive. But I would love to follow up with you from some of the materials that DBPH has on this program so you can see who it serves today and how this program would be hopefully expanding this statewide with more providers.
Thank you. Chair, follow-up? Thank you so much. Thank you. I would like that information, and I appreciate your willingness to share that. I'm curious to know, has the agency explored any other more cost-effective option to treat this population that perhaps would still meet the settlement agreement requirements?
Madam Chair, Stacey Weeks for the record. If only serving really a high acute individuals is cheap, the cheaper option is institutional care. So this is the right thing to do. Thank you.
Thank you. And I have one more question, Chair, on another item. Thank you so much. Adult dental, E267, shifting, oral health. Can you talk about the cost-benefit analysis of the proposed adult dental health expansion?
Madam Chair, Stacey Weeks for the record. We're very excited about this item. I will say that it is in this budget, and before you, we have our dental officer here today. When we look at when Mercer looked at our managed care spend, there are high costs for dental needs that come in because the managed care program has to pick up emergency. So that is on its own a high cost. And then when we look at our population with diabetes, heart conditions, dental is often one of those drivers behind that. And those are high cost populations. So when they did their analysis, they showed over time that this is a cost effective benefit that we should be covering in the state for adults. So very happy that it's before you. So we'll see where it goes.
No problem. And just to be clear, these three programs that we kind of just recently talked about with the mobile crisis, the assertive community treatment, as well as the juvenile justice services that you previously talked about in your slide presentation, those are all provider fee funded programs currently. Is that correct?
Chair, committee member Stacey Weeks for the record, yes.
And those are all things that help us come in compliance with the DOJ settlement agreement.
Madam Chair, Stacey Weeks for the record, yes, they do, but they also support adults as well. Children grow up, and so and also the state law is broad enough to also help adults. So we're looking at as much as we can. If we have money left over, which we've found that we did, we are helping the adult population as well.
I don't think I age, but although when I walk into this building, I feel it. If I can just kind of shift topics over to the children's specialty managed care plans in E268, also another recommendation to transfer from that improved healthcare quality and access budget, which I think we've all just been referring to as the provider provider tax, our provider fee, or however you want to call that, money that we've been able to utilize so well. I'm just trying to kind of understand the scope and timeline of the implementation of this. And so I'm wondering if you can kind of give a brief overview on the specialty children's managed care plan and how many children are anticipated to participate in this plan, kind of scope and timeline questions, and maybe the fiscal impact of implementing this plan.
Madam Chair, Stacy Weeks for the record. So our timeline right now, I mean, it depends on, obviously getting a vendor on board, an RFP out the door and all of that, but we're hopeful to have the plan up by January 1, 2027 at the earliest, and that's part of the DOJ settlement agreement timeline that we're putting together for implementation. What we're looking at is an integrated benefit, so it's a best practice. Instead of having our behavioral health services over here, waiver services over there, we're trying to bring it all together for a family and a child into one plan. The plan would serve 3 groups. The first group would be our foster care kids, who often have behavioral health needs. The second group would be our children who have a serious emotional disorder or designation. Or anyone, the third group, which I think we're kind of leading in the country on, is the at-risk group, because we also don't want to just stigmatize children where they have to get a diagnosis to get access. We want to help kids and provide some of these services early up or upstream. I don't know where early up came from, upstream, to help really reduce the need for some of those higher cost services. So we're looking at that population. We are looking at possibly just one plan. So we have a special plan that really has the expertise to do this work. We do have a stakeholder work group, and we will be bringing this up this summer if everything passes this year and everything is where we need it to be. We'll be building out the components of that program. The other piece on the fiscal note, I will say the admin costs, like I mentioned earlier, the capitation payment is made of 2 buckets. So you have your admin costs, which is all the work that they do that we can't do as a state, which is all the case management, care coordination, outreach, notices, all those things that they do on the administrative side. And then the other piece would be the medical spend. And right now, adding all these services is building out the medical spend we need to pay those capitation payments, and that was considered in putting those fiscal notes together. So all the medical spend that's currently in our base for this population would be part of that capitation payment. But if we do an actuarial analysis with our actuary and looking at the rates, if it ends up coming back higher, we would come back to IFC to see if there is 3177 provider tax funding, we could pull from that to help support the program. But we do not anticipating needing to, because we already pay for all of these services and we're adding them today. Or this session, hopefully.
I guess my question is, you kind of answered it. So currently, right now, the funds are kind of the funds that you would anticipate funding for the non-federal share of those associated costs would come from the provider fee.
Madam Chair, Stacey Weeks for the record, only for the administrative costs and the services that are funded from that fee. Other services are funded in our base and our state general fund, and that is and honestly, it's probably going to be a savings because they'll be actually managing the care. And so children maybe will not be over time going to these high cost institutional settings. And hopefully some of these upstream efforts will actually reduce costs over time for our base. But these services should be covered already in our base. And we'll just be instead of paying it out fee for service, we'll be paying it out on the managed care side.
Kind of shifting over to the statewide managed care implementation budget. I'm looking at some of the information that you provided to LCB for our consideration regarding that. And I'm looking at some of the costs and the savings there. It's obviously not big, but it looks like it's speeding up some of those savings. So I was wondering if you could kind of describe some of the differences between the prior statewide managed care expansion estimate, which projected a need for additional general funds over the 23-25 biennium, and what that current projection would result in general fund savings.
Chair, committee member, Stacey Weeks for the record. So the original proposal, when that was put together, assumed that all fee-for-service individuals were moving to statewide managed care, so it showed a much bigger cost. So that was one piece that's different than what we have today in front of you. The second piece of this that's different is the fact that we have actually been able to speed up our claims processing time, and we're seeing providers submitting their claims faster. A lot of this has to do with our technology and our IT team and our Gainwell and payment system. Because of that, we see a cost for fee-for-service claims after we implement statewide managed care. I will say that we are, at the advice of the LCB, we are trying to work with an actuary who is an independent contractor, because if we try to use our current actuary, it is an extremely amount of cost and it takes a long time to get all of this done with them. We're working with an actuary to do a deep dive into the data. Some of the things that she's already raised is the unpredictability of COVID data, and we're still in that phase because we are just out of the unwind, and we haven't been out of the unwind for more than 6 months. So we are just, maybe it has just been 6 months, but we haven't seen a year's worth of data on our current population. So she's updating the numbers, and we would love to bring that back to you at our next hearing, even though that count won't be before you, but we would like to bring that before you so you can see where this landed.
I would like to see that. I mean, I just have obviously some concerns from when this budget was initially introduced. You have managed to come up, and today there's a 301% savings. That represents about $41 million overnight. And so I'm just a little concerned about the timing of it.
Madam
and
Chair.
also where that, it just seems like potentially an incredibly overestimate of the savings,
Madam Chair,
even based on the speed.
Madam Chair, Stacey Weeks, the record. The reason that was overnight is because we were not aware that it was in our closing last session. I missed it. I'll own that there was a cost to the managed care for this biennium. So when we looked at that original analysis, no matter what, you're not comparing apples to oranges there. Or you're comparing apples to oranges in that, if you look at that old analysis and this analysis. But either way, I would like to say that we would like to get this actuary to finalize her numbers and bring those forward. So I think it'll be a more conservative approach. And I think maybe everyone will feel more comfortable about it.
And I'm glad to hear that, because I agree with you. I think it also, I don't know if you necessarily have the resources to be able to do this kind of in-house, and having an outside third-party actuary do this would probably cost us some initial money, but we would get more accurate information. Is that kind of correct?
Madam Chair, Stacey Weeks, record, yes, and I think that's the challenge with state government, is the reality of what we have available to us in resources. So, thank you.
Thank you. I'm trying to look at my notes here, and I can't even read my own writing. Where are we at? I asked all those. Yep. Oh. Thank God my vice chair today is very on top of it. She has questions.
Thank you so much, Chair. And I know you discussed this, and I actually thought it was a helpful discussion when it comes to the school health services. But I just, for the record, want to make sure, outside of the general fund being used to support the non-federal share of all school health services statewide, what alternatives are available to the agency to maintain the program as well as federal compliance?
Madam Chair, Stacey Weeks, for the record. State General Fund is our alternative unless you guys want to mandate counties to pay for it.
Thank you.
And I believe Assemblymember Monroe Moreno has some questions as well.
Thank you, Madam Chair. For the graduate medical education, decision units E262, E500, and E900. My questions will be from there, and I just have a few, Madam Chair, if that's okay. I'm going to take that as a yes. Could you please discuss the decision to utilize prescription drug rebate revenue to support the GME and other workforce development programs?
Madam Chair, Stacey Weeks, for the record. we try to be very lean in Nevada and our budget. And so in putting this together, one of the areas that I like that we try to do to not use state general fund is look for other resources. Our rebate account is one of those resources that does help us. Obviously, in the interim, we are able to use that funding to offset our costs in year 2 of the biennium. Any remainder, it does drop to the general fund. So it is a great resource. Because we're increasing that funding with the single PDL and some of our efforts around rebates, we felt that it was okay, and we wanted to ask if we could actually use some of that money instead of state general fund to help support our workforce and increase access to services. So it's an option in front of you, aside from just asking for state general fund.
Well, where we are with state general fund, looking at options is appreciated. So yeah, we'll check that out. And then the transfer of existing GME program to the Nevada Medicaid, the E500, E900. How would the agency utilize the $8.5 million in general fund appropriations to support enhancements to the GME program?
Chair, committee member Stacy Weeks for the record. So we would continue to follow state law that governs that fund, and we would just be managing it and working obviously with the committee that's under federal law and setting that committee up and getting them going. One of the things that we'd want to bring to that committee is opportunities to maximize that money and match it with potential federal Medicaid funds where it's available and possible with CMS, so we can get more than $9 million to go into workforce. But that would be the goal. I know I think Pazina has a bill on this. So any changes that you guys would pass, we'd be implementing under that statute.
Perfect. Yes, she does have a bill. She and I just discussed that this morning. And then my final question, Madam Chair, was why should the general fund appropriations be used to support the additional supplemental payments for the GME as opposed to contributions from the participating entities?
Managed care, Stacy Weeks record. When you say participating entities, do you mean oh, okay, sorry. Took me a second. My brain's tired, sorry. So you mean like today where we require the local, I think you'll continue to see no rural support, no support in areas where they don't have the funding to really match. I think other states have done this. They have been able to put forward state revenue to support workforce. What we haven't done in this state is actually to put state revenue. Localities are bringing forward their funding to support these efforts. So it's a way for us to go broader than just where we go today on these programs.
Thank you, Madam Chair, and thank you.
I have a couple of follow-up questions regarding this GME money. I know that in the previous session, it was our intent to make this non-reverting funds. Is that still the intention now that this is potentially housed under the Nevada Health Authority, if that should pass?
Madam Chair, Stacy Weeks, the record. There is no change to my knowledge in the budget BDR to that, and whatever you guys put in state law, we will follow.
Do you think that would be helpful just based on what you know about this? I know a lot of times standing up some of these GME programs take more than a biennium. Sometimes they take 3, 4, 5 years because you have to work with those hospital partners and those people to be able to set up what are ultimately very expensive, positions. So do you think that would be helpful moving forward if this was to go through?
Madam Chair, Stacy Weeks, the record. Yes, I think non-reverting and balance forward in the interim would be helpful to us so we can maximize that money.
And then you had indicated that obviously this would be a new standing up this workforce and using and being able to find some of these matching Medicaid dollars would be new to our state. And I think you had mentioned during your presentation that Florida is a state that has been able to utilize this. Do you know what kind of funds they've been able to draw down in their state to supplement, state-funded GME programming?
Stacy Weeks for the record. They other states do the reimbursement model, but the piece about looking at whether or not we can get federal funds to support infrastructure and other needs of providers to participate in training programs like GME, Florida is the unique one who does have a state plan amendment that is on the edge of this and that we're hoping to follow, and they have drawn down their regular federal match to support that program.
Thank you. Thank you so much. Look, we got through like the biggest one. I don't know if we have any other questions. I don't see anyone raising their hand, but they're probably all beaten down at this point. But I appreciate everyone's patience. I appreciate you. You must feel like you're on a marathon right now, but or your second or ultra marathon, I should say that. Something only Speaker Yeager has done here, I think. You've done an ultra? I feel like this is an ultra. But we will let you move on and power through. Hopefully we can get this done in the next 30 minutes. But if you can move on to the Nevada checkup program.
Madam Chair, Stacey Weeks for the record. Happy to. This is our 3178 is our medical spend for our CHIP program, which is our higher income children in our program. We currently cover about 34,000 children in CHIP or checkup. This is similar to the other account. We have our base adjustments and inflation as well as caseload changes on this slide. Same here. We also have an impact on the juvenile justice coverage item. Same impact here for some of those children who are in juvenile justice that qualify a little higher. They have a higher income with their parents and families or their caregivers, and they qualify for checkup instead of Medicaid. Coverage of school health services, the same thing here. We're picking up those costs to ensure that we can continue to cover these services in compliance with federal law. The other item here is our behavioral health services to support some of our children's behavioral health work around the Department of Justice. This piece would be funded out of the provider tax program. Similar here, mobile crisis. This is just the population that would be impacted by the rate increases we've already talked about. And same for these services here. And here, and here. And I'll stop there for questions. Thank you.
We'll go to Assemblymember Brown May.
Thank you, Chair. Thank you. I just have one question, and I know that, so it's M151, the FMAP percentage rates. I'm just curious to know, we know FMAP's changing a little bit. It looks like the Nevada Checkup Program doesn't show any changes to federal revenue, but in just expenditure categories. Do you think that there's any adjustment necessary for that M151 decision unit to remove some expenditures to account for reductions?
Chair and committee members, for the record, Lynette Aaron, yes, we would like to submit a technical adjustment to include the decrease in federal funds.
Do we have any other questions from the committee? Seeing none, we will pop into this last budget, which is, I'll close that one and move on to 3164, the public option. And I don't know if you have, I see a little bit of a presentation here. And I know, just point of privilege, I know you've worked so hard to implement this. And it turns out all the opposition that we heard during the presentation of this bill, it seems like you've been able to maximize this, and I appreciate the governor for being able to take this and continue the good work that we've done on Senate Bill 420. So I will go ahead and turn this over to you for the presentation.
Thank you, Madam Chair. Stacey Weeks for the record. So budget account 3164 is our public option account. It's a special account that we have to collect any funds that support this program. It consists of right now state funding. It will soon consist of, if everything continues to go the same way it has at the federal level, because we got our waiver approved, it will include, as of next April, some federal funding that we have saved in the exchange. It also includes funding savings from not only the public option target, the reduction target, but also the governor's reinsurance program. Those two together bring in additional federal funds to the state of about $300 million over the next 5 years. Here is just the additional money that we need to continue this program. Under the new agreement we have with CIO and CMS on this program, we need an actuary to support the program and the expertise. Every year we're going to be looking at proving how much we've saved the federal government. So while we went through this very long process, I honestly feel like it was harder than Medicaid waivers. I'll be frank with you. I thought those were hard. This waiver was hard, and we are dealing with the Treasury actuaries. And so to have an actuary who has experience with this program and knows what we need to put forward to maximize the federal funding, we need these services to support that. We also are required to have certain reporting that only we believe an actuary should and can be doing. So this funding here supports that ongoing support for us in the next biennium with this waiver and program. And I stand for questions.
Oh, I think you know who we're going to. Majority Leader Canizaro.
Thank you, Madam Chair, and thank you for all of the amazing work that you have done to help kind of bring this to a point where we are today. I know how hard that waiver was, and am so grateful that we were able to get that approved. And this is just such a wonderful place to be able to sit here and ask you questions on this budget account and some of I think the proposals that are contained within this and that I think will ultimately help with our overall healthcare access here in Nevada, and also providing so many Nevadans a way to get affordable and accessible healthcare that will allow them to get that care without being one of those more acute cases that is uncompensated for, that ends up in our emergency rooms and drives up costs across the board. And so I appreciate the moment to take a little point of privilege to just say thank you for all of your hard work on all of this. And it's just fantastic to be here to get to dig into the details. So I know that part of this has a couple of programs here for the Quality Incentive Payment and the Practice in Nevada program. So to what extent do you anticipate that federal pass-through savings will be sufficient during this biennium to operate either both or one of those programs?
Chair, committee member Stacy Weeks for the record. So under the waiver, the money is treated as waterfall funding. So just back up to make sure we understand. So we don't have to fund all of them every year. We fund what we have the money for. We first start with the premium relief program because anytime you lower the second lowest silver, you are going to see increases in some areas of the market. So there is money there to neutralize and lower that with the premium relief. We do believe in year one we have enough for premium relief and a full reinsurance program, which is not originally what we proposed. It was year two. So we do have enough for year one. With thanks to the Treasurer's help, the U.S. Treasurer's help, I think that was actually a really good thing that came out of that. Year two, we believe we'll have enough for, again, the premium relief, the reinsurance program, and a small quality program for health plans and providers who are meeting certain metrics in the private market and aligning that with Medicaid in a way where we're really supporting and reducing duplication of reporting across providers and trying to get at some of our quality needs. And then the fourth year and fifth year, we do believe we'll have enough money for all of the programs. But at this time, it's really, we'll have to work with CMS and argue for every penny, I'm guessing, as we move forward.
Yeah, and I would anticipate that probably is the case. But I do think that one of the nice things that I think we have here is a good understanding of those projected costs and how that will come. And obviously it's going to take maybe a couple of years at least until we get some of those funds. But I do think that both of those are great uses of dollars. And so just looking forward to making sure that we can help to kind of stand those up. Can you also confirm for us that general fund appropriations will no longer be needed to support administrative costs in the public option budget account following the receipt of that federal pass-through funding?
Chair, committee member Stacy Weeks for the record. I do believe we're still going to need some funding so we can make sure we have enough for premium relief in year one and year two of the program. But after that, we should have enough for all administrative costs, including actuarial services.
Yep, and I think that makes sense. Can you, and I think you maybe have touched on this, but can you discuss why actuarial projections related to pass-through funding for the 2025-27 biennium are not included in the governor's recommended budget?
Madam Chair, Stacey Weeks for the record. I think they are included in the governor's budget, the actuarial services. They are. It's just it's on top of our base that we currently have in the budget. So I apologize if there's confusion on that.
Okay, no, that clarification is very helpful. And so I think those are all of the questions that I sort of had today. But again, I just you've done fantastic work, and I'm just so proud that we get to talk about this. And then I think that we can also have other conversations. I know I mentioned this before when we first heard about the Nevada Health Authority. I think that what we're seeing here is a model that I'm anxious to see after those first couple years, that pass-through funding come through and show us that we can leverage the state's purchasing power to help buy down costs for consumers. And this is sort of a real way for us to take a look at that, and obviously is very similar to some of the mechanics for the health authority and how it is that would help ultimately with consumer costs. And so I am very excited. I can hardly contain my excitement. I thank you so much for letting me ask some questions, and thank you for being here and walking us through all of this.
Do we have any other questions? No. Thank you, thank you, thank you, thank you. I know I will tell you to take some time for yourself and take care of your mental health, but I don't think you will have any time until maybe 3 months from now. But we appreciate you guys. I know we had a lot of questions. I know we had a lot of hard questions, and I appreciate your candor. I think you have a preview on some of the things that we want to see some more information about in some of the upcoming budgets, including the provider fee or the budget, which has a longer name that I can never remember. But thank you, thank you, thank you. And with that, we will close this final budget for today's subcommittee. And we will move into our next topic, which is our next agenda item, which is public comment. I'll remind everyone to please state your name for the record. Because we have floor coming up, I'd ask you to limit your testimony to 2 minutes. And go ahead and fill in those chairs and begin when you're ready.
I scared everyone away. Good morning, everyone. Dan Musgrove, Strategies 360, today representing the Behavioral Health Solutions. On your desks or on your Nellis is this document. My client, Behavioral Health Solutions, is very involved in the BCC program. This is a true success story for Nevada, and my compliments to Medicaid and the teams that have been involved with this for I think, close to 10 years that this program has been in place. BCC is something that I think Nevada was one of the first to implement, and now we as a provider, BHS, is in 8 states, and we are working in approximately 250 SNFs, skilled nursing facilities, across that 8-state footprint. There are current legislatures looking at 5 more states at adopting this program, and it's really based on the work that Nevada did. The nice thing is that because Nevada has been doing this, we've got good data, and I want to direct your attention to pages 17 and 44, which is E275. You had already some good questions about this regarding the bonus program that is being proposed to you in this budget. Right now, we are seeing huge cost savings to the system because of this program. Many of you know that I represent hospitals, and it's been an honor for me to bring BHS to those hospitals. Working with NHA, we are, as hospitals, are very excited about this program because, as you can see on this document, on any given day, there are a number of individuals that are languishing in acute care hospitals because there is no safe place to put them. And this program makes it so that skilled nursing facilities have the capability in handling these patients because they've been trained, their staff is more receptible to them, and because of the bonus, there is now an incentive. We were lucky that Assembly Speaker, Majority Leader, and the Chair of Ways made a visit earlier last year, at a SNF that has a very robust program, and I think that they were amazed to talk to staff and understand how they're welcoming of these very hard to deal with patients, and it helps our system. There is cost savings to the system, and we would ask for your support. Thank you very much.
Thank you. I don't see anyone in Las Vegas. I don't see anyone further here in Carson City. If we could go to the phone lines to see if we have any testimony in public comment. Again, I would remind any of the callers to limit your testimony to 2 minutes. Go ahead.
If you'd like to provide public comment, please press *9 to take your place in the queue.
Good morning, Madam Chair and all of the members of the hardworking committee. This is Dora Martinez representing the Nevada Disability Peer Action Coalition. Sorry, I'm a bit bratty. I'm walking with my service dog. I want to thank Miss Stacy Wicks for her thorough reporting, and thank you to all the questions that you guys ask. And we urge that hopefully, we can work something out so people with disability and elderly and everyone who's on the Medicaid will not lose the benefit. And I just want to thank Tracy and her people at the ground level where the welfare office is at. Reno and Sparks, I've been helping some elderly folks who do not have access to internet. We go there in person, and the security guard will approach us and help us to check in at the counter. So we appreciate that accommodations, and thank you for all that you do. Have a great day.
Thank you. Do we have any other callers?
Chair, the line is open and working, and there are no other callers at this time.
Wonderful. And with that, we will close public comment. I will thank the committee members for their diligence in getting through these probably our two most substantial budgets that we will see in this subcommittee. And with that, meeting is adjourned.